Greetings and welcome everyone to the workshop on allocation of COVID-19 monoclonal antibody therapies and other novel therapeutics. This is a two-day exercise sponsored by the Standing Committee on Emerging Infectious Diseases and 21st Century Health Threats at the National Academies. I'm Harvey Feinberg, and I have the privilege of chairing the Standing Committee. This workshop is intended to inform a rapid expert consultation on the topic to be prepared by the Standing Committee. We are undertaking this task at the request of the sponsors of our Standing Committee, which was stood up last March at the request of the Office of Science, Technology Policy and the U.S. Department of Health and Human Services Office of the Assistant Secretary for Preparedness and Response. We're very privileged to have participating in this workshop many members of the Standing Committee who participated in the planning of it. And I want to acknowledge, especially also at the outset, the hard work and superb performance of our staff who put together the program, invited the participants, and helped organize these proceedings in a very short order of time. We're very accustomed to moving briskly these days. I want to thank especially our colleagues at the Office of the Assistant Secretary for Preparedness and Response, which we call ASPR, Bob Kadlik, who we'll be hearing from in a few minutes, Chris Hassel, and John Redd, especially, for their help in framing the questions and helping us to undertake these discussions. We're going to be spending 4 hours today and 4 hours tomorrow on what could properly be described as a wicked policy decision, meaning not that it's evil, but that it is complex and not readily susceptible to a simple, straightforward, analytic conclusion. Once, when referring to Russia, Winston Churchill famously described it as a riddle wrapped in a mystery inside an enigma. We could perhaps similarly think about the challenge of monoclonal antibody distribution as a decision problem inside a shortage wrapped in a surfeit. The shortage is the shortage of drug relative to the clinical need. And the surfeit is the excess of new cases that create the underlying demand for the drug. How do we come to grips with this question? From the federal level, there's a distribution question to the states that we'll have a chance to hear about. But then the states have to distribute the limited supply of drug to delivery sites. And those sites in turn have to decide which patients do and which patients do not receive the drug in limited supply. It's a wicked problem because the goals are ambiguous, unclear, and controversial. In a case where helping every individual patient with ample supply is available to us, helping each individual is tantamount to improving the health of the whole of the population, cumulatively, one at a time, doing our best for each and every patient in front of us. But when we're facing a shortage of available drug relative to the array of patients who may benefit, the choice is not so simple, and the decision is complicated by the fact that these are time-dependent decisions. The value of the drug is not permanent, only in a certain period, and the patients who benefit are not always going to benefit to the same degree, even if for each individual it would be beneficial. How do we think about those who are disadvantaged relative to those who have more access? How do we think about the practicalities of administration, making it possible for the monoclonal antibodies as deployed to be used successfully? All of these questions, including the ethical dilemma of uncertainty, and when a level of probability gets so small as to dissolve into ethical equilibrium of a choice that we cannot with confidence make based on the science as it is known. These are the challenges. These are some of the dilemmas, some of the difficult, wicked aspects of this problem that we will be trying to come to grips with over the next 2 days. I'm really looking forward to the discussion, and I know all of us look forward to learning from one another. I'm especially pleased that we have with us the president of the National Academy of Medicine to offer his opening reflections, after which we'll turn to Dr. Robert Kadlec, the Assistant Secretary for Preparedness and Response, and proceed after that to our program. So, Victor, welcome this morning. We're delighted to have you virtually with us, and we look forward to your comments and charge to the workshop.
Thank you very much, Harvey. Thank you for opening the meeting. So I want to thank all of you for coming to this workshop. It deals with a very important topic, the topic of equitable allocation of COVID-19 monoclonal antibodies and other novel therapeutics. Late in October, I was contacted by Dr. Alice Chen, the Deputy Secretary for Policy for the California Department of Public Health. And she brought her concerns of her peers to my attention. Anticipating the emergency authorization of COVID-19 monoclonal antibody, she asked if the National Academies would undertake a study on the issue of equitable allocation and other related issues. I reached out to Bob Kadlec, whom you hear very shortly, and I suggested that we have a standing committee at the National Academy and whether we could tackle this issue. But fortunately, he and his team, Chris Hassel, John Reed, Paige Waterman, were already on it. And you'll hear shortly from John Reed and others about the current state of efforts around the allocation of the monoclonal antibody from a policy level perspective. But there's a lot of details at the local implementation level that still needs to be addressed. And so in response, under the leadership of Harvey Feinberg, the Standing Committee met in November 15, and they've been working towards this very important day and towards eventually a rapid expert consultation. So let me lay out the issues. There are logistic, scientific, ethical, and financial issues. First of all, as of last Wednesday, to my knowledge, there's 77,000 doses of the Regeneron cocktail and 260,000 doses of Lilly's monoclonal antibody. Well, if you do the math, you know that we are seeing 200,000 cases and more a day, so the supply certainly will not meet the demand. Secondly, the monoclonal antibodies to be given to an early stage with mild symptoms within 10 days of onset of symptoms. And of course, there's clear guideline about when to give it, how to give it, and who you should give it to. Third is to be given as an outpatient, as an infusion. Require 1 hour of infusion and 2 hours observation. So you can imagine the logistics. Where do you do it? In the clinic, emergency room, infusion centers? Fourth, of course, is the issue of reaching access to the population. Here you talk about how do you reach the vulnerable population and the rural setting. And another one is payment. While the monoclonal antibody is free, there are people who don't have insurance, and there's got to be or likely to be an administrative copay or some kind of cost that needs to be covered. So that certainly aggravates the issue of equity as well. And then finally, this is also a global issue. So we have, in fact, a speaker on the global aspects of this issue. This is why we got you together today to have this public discussion, to learn from each other about assisting decision makers, those considerations, and their efforts to equitably allocate COVID-19 monoclonal antibody and therapies, and also other novel therapies at the state and local level. And secondly, is to look at barriers, those barriers to access, particularly a population at high risk, and also administrative capacity, cost, data collection, of course, and reporting. So we're so glad that you're all joining us today. And I want to turn over to the Assistant Secretary of Preparedness Response, Dr. Robert Kedlick, who's been such a leader in this area. And I thank him for joining us, but also at the same time, thank him for taking leadership in this area. Over to you, Bob.
Well, thank you very much, Dr. Zhao, and Dr. Feinberg. Thank you so much for your opening comments. And we are truly grateful for your involvement in this and your leadership within the community and at the National Academies to convene this group on such a vital topic. I have to think that we're at this very moment at an unprecedented milestone of this current pandemic, and really the unprecedented nature of the products that I think you've correctly identified as being challenging from both the logistics and from the clinical aspects, as well as the ethical opportunities to ensure fair, equitable, and I would just add one more word to that, effective allocation, distribution, and administration of this product. Stakes are very high as I see them from my perch. You've noted the number of cases that we're experiencing daily and the number of hospitalizations currently that have been reported, 110,000. And we only see that climbing. If we can find the virtue and value of these products in a way that ensures the ethical and equitable distribution to basically ensure that people have equal access to this, but also ensure that the people who can benefit most from this for a clinical benefit are the ones who receive it, as well as the opportunity to ensure that given the nature of these products and the potential at least that has been suggested, though the data has not been, I think, collected and confirmed to this point, that it could be very essential in preserving our healthcare system in light of the demands that are being placed on it, not only from the COVID disease itself, but just ensuring the integrity and capacity of our healthcare system to deal with the non-COVID events, both acute and chronic, that we know are occurring simultaneously to this pandemic. So I'm going to be all ears and be taking notes furiously as I listen to your discussions today, because as you'll hear from John Redd, we've devoted a fair bit of not only time and effort, but we've brought the best of our team together, led by Dr. Redd, to basically try to find both a fair, equitable, and effective means to employ these tools, as well as future therapeutics that we can do, that we can bring to bear to advantage patients. And again, as we say in our business, save lives, and again, protecting our healthcare infrastructure so it can be available to our communities around the country. So with that, I'll stop. And again, thank you, Dr. Feinberg, Dr. Zhao, and all of you for your time, commitment, and contributions that I look forward to hear about today. Thank you.
Well, thank you very much, Dr. Kadlik, and Victor. Thanks so much. Thank you so much for your comments as well. I think we've heard the issues in a very broad brush form. Victor alluded to logistical, scientific, ethical, and financial issues. Dr. Kadlik talked about fairness, equity, and effectiveness of distribution. I want to just take a moment, Dr. Kadlik, to thank you, not only for your confidence in the National Academies over this critical period, but for your service to our country, which we also very much appreciate. And now I want to turn to our first panel, which is an overview panel. This panel will be moderated by Kent Kester. And Kent, if you're standing by, let me turn over to you now for our first opening discussion on an overview and background on the issues.
Okay, thanks, Harvey. I'm Ken Kester from Sanofi Pasteur and a member of the Standing Committee. So this first panel really focuses on really kind of big picture policy aspects related to monoclonal antibodies and their potential allocation. So in the interest of time, we're just going to get started. Our first speaker is John Redd, who's the Chief Medical Officer in the Office of the Assistant Secretary for Preparedness and Response, ASPR, in the Department of Health and Human Services. John, are you on?
I am, yes. Thanks, Ken. And I want to say thank you very much to Drs. Feinberg and Zhao. And my video doesn't seem to be, oh, yes, sorry. They've just asked me to start. Very good. So Emma's going to share my slides, and then I'll say when to advance. So it's a great pleasure to be here and to have this really crucial discussion. And we very much appreciate the support of the academies on this activity. So while the slides come up, I'll say that this activity really began back in May when we were asked to go ahead and come up with a system for allocating and distributing remdesivir, which you all remember. Now, remdesivir, for its part, was in many ways relatively easy. Of course, that was a very difficult time in the pandemic, as we're in now as well. But in the case of remdesivir, the challenges were in some ways easier to solve. First of all, remdesivir was only approved for patients who were inpatients, as opposed to these medications. And secondly, remdesivir, oh, the slides are up, okay. I can't see them. One sec, let me, maybe I need to switch my view.
It's on your opening slide still, John.
Okay, I've still got a spinning beach ball of Emma Fine has started screen sharing, but I have my slides up. This is looking better. Let me just I'll just follow along on my computer here.
Are we able to advance the slides?
Yes, I think Lisa will be able to.
Okay.
Emma rather will be able to. So
okay.
Let me start then. I'm assuming I'm on my my intro slide with my name. So yeah, this is Dr. John Redd, and I'm the Chief Medical Officer at ASPR. And as I mentioned, I've been leading the effort to allocate and distribute therapeutics since May during remdesivir. Let's go to the next slide, which is slide 1 with the USG state governments and administration sites. And for those of people who have not been part of any of the other outreach that we've had, what I was asked to give today, and I'll be very happy to discuss and comment in other parts of the discussion, but to lead things off, I wanted to give a fairly high-level view of how the system works, what its ethics are, and what the data are that we use to try to make sure that we do this fairly. So if you look at this diagram, this is the current monoclonal antibody allocation process. Because these products are scarce, and I'll go into some of these ethics in just a second, but because these products, as we mentioned, are scarce, it's incumbent upon the United States government, which has procured them on behalf of all Americans for use all across the United States, that we use them in a way that is transparent, equitable, fair, and understandable to citizens on whose behalf we are acting. So given that, as we mentioned, unfortunately, the current situation is that the products are scarce enough that not everyone can get them. Demand overall does exceed supply. The US government maintains allocation control over the stock to ensure fairness and equity. We very squarely and very deliberately have placed state governments in between the United States government and the administration sites. And the reason for that, we'll go into in detail, but the main theme here is that as opposed to remdesivir, which we're used to, there's a great variety. We're up well over 3,000 sites now, but there's a great variety of potential destination sites for these monoclonal antibodies. That includes, but is not limited to, nursing homes, hospitals, Indian Health Service facilities, and direct to pharmacies. So that's the first theme that I would bring your attention to. Next slide, please, Emma. So slide 2. So let's go over the principles for federal allocation in the condition of a resource being scarce. And bear in mind that we're going to have other scarce resources, unfortunately, but that's the way it is before this pandemic is over. So these are principles that we have stuck to. First, we have always intended to maximize the use of existing infrastructure, and that is whether it's USG infrastructure, manufacturer, or distributor channels. Secondly, as I referred to, we allocate to state governments when the product is scarce. I want to discuss it at some length, the principles that we use in terms of our equity principles. And there are two main themes in this. And we have worked since day one with the NIH bioethics group, which has been very helpful. There are two main ethical principles by which we abide. The first is fairly easy to understand, although it can be difficult to execute, which is geographic equity. And that refers to the fact that no one in the United States should be more or less likely to receive these products or any others based solely upon where he or she lives. And you can extend that to based solely upon what healthcare facility he or she is in and other features. But that, in essence, is geographic equity. Temporal equity is actually a little bit more subtle and can also be hard to execute. Temporal equity refers to the fact that we know that there are not just patients who need to be treated right now at this instant. We know by definition, looking at the epidemiology curves, it doesn't take a modeler to know this, that there are going to be many more cases to come before this is over. And so what that means is, in order to establish temporal equity, is we have to, in a sense, advocate ahead of time for patients who are yet to come. And that can really be challenging. As I alluded to, states are responsible for allocation to the final points of care. That, again, is deliberate based upon their knowledge of their local situations. And as under the emergency use authorization, the manufacturer tracks pharmacovigilance and follows the mandatory reporting guidance. And in terms of the state's allocation to a final location, I would just want to say, I want to give one example about how this is pertinent. As we'll see in the next slide, we work on specifically on given data points in order to make fair allocations. But we are very cognizant of the fact that an institution that is most under stress, that has the most patients, what have you, is also the one that's least likely to report well. So part of the reason that we put the states in between product and the destination sites is because states will know where those locations are. If you imagine a facility that's been overrun and their infection control nurse is so busy that he or she can't fill in the data that he or she ought to be doing, under normal circumstances. We don't want to penalize those patients, and states know where those patients are. So let's go ahead to the next slide, which is the two data sources. So the two data sources that we use for this purpose are confirmed hospitalizations. So that is 7-day incident hospitalizations. Those are entered on a daily basis via teletracking, which is a method of entering data into HHS Protect. And that's simply how many confirmed COVID-19 cases have you admitted in the last 24-hour period. We sum those up over a week, and that's the hospitalization data. We use that as the acuity portion of our analysis. These data at this point in the pandemic are very complete and very timely. 98% of facilities report at least weekly. And then the other portion of cases that we use are the total confirmed cases of any type, outpatient, inpatient, anything. And those, of course, greatly outnumber the hospitalizations by 10 or 11 to 1. But the reason that we like to use those is because they contribute the overall magnitude of the caseload. And most important, current total cases, unfortunately, represent a view at the future of hospitalizations in a couple weeks. Next slide. So this is the allocations and the weighting. So the our process is not so formulaic that it's literally done by a computer or something like that, but it is based to begin on looking at data and then looking at how those data would lead to distribution. So I wanted to go over the example that we're using currently for how we're allocating these outpatient infused antibody therapeutics. So the weight that we use to get a weighted case count is that we use all hospitalizations. So the weight of hospitalizations is 1. The total hospitalizations, the total confirmed cases are weighted 0.1. So each state has a corrected case count that's equivalent to 1.0 times hospitalizations plus 0.1 times total cases. Once we've done that, we do that to all the states and jurisdictions. We add that up, and that is the national weighted case count. And each state receives an allocation that's equivalent to its portion of the total national weighted case count. So let's see where this has led us in slide 5. This is an example. This is the cumulative allocation to states, and this is current as of first thing this morning. And so this will give you by state what the total number is. We have allocated approximately 337,000 patient courses of monoclonal antibodies. And I should mention that we go very strictly on patient courses. And the reason for that is that currently there are 2 of these EUA approved products. The Lilly product is a single monoclonal antibody, of which 20 milliliters are added to a bag for infusion. The Regeneron product is 2 separate antibodies that must be combined to placed into the patient. So to reduce confusion between the products, we speak strictly in terms of patient courses, which in this case is a single infusion. So you can see if you look at the map that we also include the federal allocations to Bureau of Prisons, Defense, Department of State, Indian Health Service, and those locations, and American territories all over the world. And then lastly, I would turn your attention to the takeaways. That's in slide 6. So through this method, we've been able to allocate approximately 337,000 patient courses. We deliberately divide resources among states as per many, many other emergency management plans. The states have flexibility to determine allocation within their individual jurisdictions. We don't just send the product to states and then leave. We follow very closely where product is being delivered, how quickly it's being delivered completely, and those things. But the states, often with our support and consultation, are making the final decision on where it goes. And then the states do not necessarily need to follow the federal model for utilization in their jurisdictions. Many do, though, use an analogous system to ours, which is data-based. And that's all I have for this morning. Thanks again to everyone. I'm going to pay very close attention, and I really look forward to answering questions. Thank you.
Thanks, John. Okay, going on to our next speaker, Marta Wazinska, consulting professor, deputy director of policy at the Duke Margolis Center for Health Policy. Marta, are you on?
Yes.
Okay.
Thank you so much. Can you hear me?
Yep, take it away.
Thank you so much. So thank you so much for inviting me to speak about this issue. We started thinking about the possibility of shortages for monoclonal antibodies back in April, I would say, when we started hearing that these might be coming to market, that these are being developed. Based on our experience actually working on drug shortages and knowing a little bit about the manufacturing process for these drugs. So actually in June, we issued an issue brief that looked at the manufacturing capacity for monoclonal antibodies and also tried to do a back of the envelope demand estimate. And depending on if it was for hospitalized patients only were to be the indication, we probably would have sufficient supply. But if this was going to be in outpatient setting, or in particular in prophylaxis, we would definitely face a problem. So then at that point, we turned to thinking about how could we help prepare for these shortages. So this work is supported by a grant from Arnold Ventures. So we're very thankful for them to support this work. If we could go to the next slide. So we've already said this, that COVID-19 monoclonal antibodies have a great but uncertain potential. So the trials submitted for the EUA have shown a reduction in hospitalizations in high-risk patients. For example, for bamlanivimab, it was 75% the reduction was 75%. It was 67% for the combination product from Regeneron. But these were relatively small trials, and there's a low baseline risk for this. So it ended up being with the number of patients that actually ended up being hospitalized was actually pretty small. The trials also did not necessarily hit their primary endpoint. So there's a level of uncertainty around their value. For example, the IDSA, the Infectious Disease Society for America, had issued a conditional recommendation against the routine use of bamlanivimab due to very low certainty of evidence. And NIH said that at this time, there's not sufficient data to recommend either for or against the use. I'm bringing this up for two reasons. One is that our healthcare system is extremely stressed, and we have heard that there's sort of unease from providers about whether it's really worthwhile to be standing up a whole new system to deliver these drugs, because it does require really rethinking about where and how infusions are delivered. So that's one aspect of it. And frankly, this does also drive some of the allocation decisions from this on the state level. And I'll talk about this in a second. If we could go to the next slide. The number of hospitalizations, which you can see here in blue, has already been brought up as an issue. If you look at the number of hospitalizations there were when the first monoclonal antibody came to market, they were basically half of what we have now. If the numbers that you see in clinical trials were really to stand up, we're talking about potentially a 75% decrease had we have the amount of product to be able to do it. And so while we have vaccines already and they're starting to be distributed, we're still in for a few really rough months. So these drugs potentially could really help bend this curve, which would be really important. If we could move to the next slide, please. So how do we think about what the issues are? I would suggest that a good way to tackle this is to think about how to identify the right patients. And again, a lot of it has to do with the fact that there's a shortage relative to the potential use. How do we find them at the right time, which is early in disease progression? And how do we think about the right place? And here, it's both the provider burden and their willingness to actually try to stand up operations, and also where the patients actually are. And I think I would suggest that what's really important is that we don't think of these monoclonal antibodies as remdesivir. It is true that the federal government is involved in the distribution, and we had a model to go off of, but how we think about the right time and how we think about the right place is actually going to be very different than for remdesivir. If we could go to the next slide, and I'll dive into it a little bit more. So let's first think about the right patient challenge. So we have seen the numbers of how much supply has been distributed so far. In the first month, the total number of courses was over 300,000. The EUA criteria for these products are very broad: over 65, or BMI of over 35, or there's certain comorbidities. This is just this visual here is just to show you sort of the mismatch. There were 50 in the same month that in the first month since the first monoclonal came to market. We have had 5,200 new confirmed cases, which you can see here in green are 60.5% are people who are over age of 65. And then those are actually not data from this is sort of, we're applying 16.5%. We actually don't know how many of those who were confirmed actually are of that age. And then of the remainder, just 40% have a BMI of 35%. So we might, you can see where the mismatch here happens. If we could go to the next slide. So shortages are not new to providers, unfortunately. And in a typical shortage, providers are forced to decide how to narrow eligibility criteria. And the two key pieces of information is information on future supplies and on clinical data. And they actually sort of intertwine with each other, because frequently what happens is that a manufacturer will communicate with the provider, and they will basically say, I know you have been ordering this much, but for the next 2 months, you're only going to get 20% of that. Or, and with that, the providers can then go to the clinical data to say, out of the patients, how do we prioritize patients? Remdesivir and the monoclonal antibodies for COVID have been actually very different from these typical shortages for a few reasons. Number one is that the federal government and the states are involved. They are usually not involved in this process. The available future supplies are not known outside of HHS. So providers don't know, frankly, the states, how much more of the product is coming. But as I said, it sort of feeds back to how do you think about using clinical data and prioritizing and thinking about this intertemporal equity as well on their level. And there's also pretty limited data to support narrowing eligibility beyond the EUA high risk. But as I indicated, that group is very large. It's potentially more than half all the cases. So states have very differently embraced their new role. Some have set up allocation boards that involved health system participants. That was frequently done for remdesivir. And many states seemed to have called back these boards to advise with allocation of monoclonal antibodies as well. But for what we have seen, and we have been following and gathering information about what some states are doing, it's still a relatively small sample, but from what we have seen is that for monoclonal antibodies, the states generally did not feel comfortable narrowing the criteria, these state allocation boards deeply. We have seen, for example, one state based on safety data, the fact that pregnant women were not studied, exclude pregnant women. In another case, that those under 18 would not be eligible. But those are sort of issues on the margin and not really truly prioritizing. Where the states have been more comfortable is saying, there's just not enough data, and if we are to provide guidance, we recommend that you actually do a lottery, and that's sort of a way to prioritize to deal with equity issues. If we could go to the next slide. But because of the limited data, to a large extent, it's the allocation decisions, the true allocation decisions are being really passed on to providers. Providers seem to be using two approaches for narrowing or for handling the next step. One is to rely on a lottery, which is usually based on a state guidance. This is not really narrowing of criteria, but this is how you prioritize patients. Many other providers are relying on baseline risk. And something to highlight what comes out, for example, those are numbers from the mAbs study, is that the number of patients needed to treat to prevent an ER visit or hospitalization with that drug was about 10 patients for the high-risk group versus 21 patients in the full study cohort. But what was also interesting is that that 10 versus 21 seemed to have been really related to baseline risk, the fact that high-risk patients had a higher probability of having an ER visit or hospitalizations than low-risk patients. So if you were to take that logic, if you could further prioritize high-risk group and say who are really the highest risk patients, perhaps you could even get the number needed to treat to a lower number. And using that logic, on the right-hand side, there's actually a tool from the Cleveland Clinic that we understand a lot of providers have been using, where they actually look at the baseline risk of hospitalization, and some providers have been using that to prioritize patients. And we also understand a lot of large health systems that have had these data have been also developing their own tools like that. If we could go to the next slide, please. So the next piece of it is the right time challenge. And this is again where we diverge from remdesivir. We need to infuse this drug within 7 days of symptoms, but patients generally don't seek care until they're quite ill. We have been telling patients, if you're not really sick, don't come to the ER. Stay at home, take care of yourself, isolate. And here we actually want to capture patients really early. And then also many other parts of the process can have delays. If you look on the right-hand side, there's a number of things that have to happen before an infusion. So a patient gets infected, the patient has to seek a test, then the patient has to wait for the test results, then has to get a referral, and then schedule an infusion and get an infusion. And this can take a long time. The turnaround time for tests alone, for example, apparently caused problems in some of the clinical trials because it was during the summer, it was taking so long for test results to come back, is that some patients were basically ending up timing out of the 10-day window. And also just simply that patients were not even signing up for clinical trials because again, patients' willingness to engage in something like this is much greater when they're really sick. So there's definitely a role for providers here to advance this process. This does not limit the criteria, but you can see that there's, depending on which setting you are in, this process can play out very differently for different patients. So if you're in a health system, an integrated health system, you might get a test within the system and you can really expedite the process. But for patients that potentially are outside of a major health system, this whole process can really get stalled. So there's also an important role for the states. A really good place for screening high-risk patients could be at testing sites. And again, a lot of patients get tested outside of health systems. And so there's an opportunity there. There's an opportunity for states to check for health system and facility readiness and their capacity to actually deliver this in a timely manner. And there's an opportunity to support efforts to streamline the test to infusion timeline. If I could have the next slide. And then there's the right place challenge, where to do infusions. And I would say this is probably where there's a lot of opportunity to address inequities that might result by addressing where to do the infusions. So this is the really complicated graph that Dr. Red showed us earlier. I wanted to zero in on exactly what he showed is the role for the state governments is to determine who should be appropriated the product for further distribution. And if we could go to the next slide, I'll talk briefly about why that matters. So phase 1 of distribution only included hospital systems and hospital affiliated locations. That made sense from the perspective, for one, this is how potentially remdesivir played out, but also those systems were likely much more ready to tackle take on this drug. But let's think about it sort of in phase 2 and beyond, than phase 2. So there's really 2 pathways to do it. One is sort of the traditional way to do it, which is to bring the patient to the infusion site. The other one is to bring the infusion site to the patient. So some of the questions that arise on the bringing the patient to the infusion site is, how do you address the need? How do you deal with staffing shortages and the need for doing COVID precautions? You definitely don't want to be sending these patients to the ER. Appropriating existing infusion sites can be really challenging. A lot of infusion sites, centers actually have immunocompromised patients. You have to really think, to take on a lot to be able to manage that process. This by itself is going to create potential inequities in that it's much easier to set up an infusion site in an urban area because you can reappropriate, sort of move patients around, you can move staff around, you have the footprint, but it does make it much harder, for example, to create access for patients in the rural areas. Similarly, how do physicians not affiliated with hospitals refer patients? If you could flip really quickly, Emma, to the next slide, and I'll come back to this one in a second. So for example, NICA, which is the National Infusion Center Association, has a tool where you can actually look up where a particular drug could be infused. They don't have this kind of information available for monoclonal antibodies. But what we have heard is that some patients who are not affiliated, their physicians are not affiliated with hospitals, are basically timing out in the 10 days since symptoms because their doctors don't know where to refer them to. If we could go back to the slide. And then, how do you reach vulnerable communities? Again, I'm thinking not only about the rural setting, but some other in urban settings where patients don't necessarily engage with the healthcare system. Thinking, for example, about the uninsured population or some underinsured populations that might be highly vulnerable. The other model is bringing the infusion site to the patient, which is really a home infusion model. One thing that we heard through our project is that patients in long-term care facilities who have mild or moderate COVID are not going to be taken to infusion sites. It's just given the pressures on the staffing shortages, this is going to really cut out patients in long-term care settings unless the infusion is brought to them. So something that we were proposing is to really try to support and expand the home infusion model in long-term care facilities. And then just more broadly, how to scale the home infusion model. So if I could go to the next slide and then I'll wrap up. Oh, I guess we have already seen that. And next, please. So I guess one thing, and maybe this is a great point for discussion, is how does vaccination of high-risk groups, what does this mean for COVID mAb allocation? One question that comes to mind is what will happen, and we hope to see more guidance around this, is should patients who have received one vaccine dose be eligible for COVID-19 mAbs? They might still be sick, but it will be important, I think, especially in the long-term care setting, to have some guidance on this. But the priority groups might actually change once vaccines are being administered in settings like long-term care facilities. So that's just something to consider. We understand that there's a number of pilots happening in those settings, but I wonder whether we should be thinking of some other settings where there are vulnerable patients that might not be far up on the list for vaccines. And then next slide, please. Just to mention, we have done a lot of work actually on monoclonal antibodies. A colleague of mine is going to be speaking briefly tomorrow about paying for administration and better evidence. So I would refer you to our website if you're interested in more, and I'm happy to answer questions.
Okay, thank you very much. We're going to hold the questions till the end, till we get all the talks through. So thanks again. Okay, for the last subsection of this session on other policy level perspectives, next speaker is Michael Ganio, who's Senior Director of Pharmacy Practice and Quality, the Center for Medication Safety and Quality at the American Society of Health System Pharmacists. Michael, are you on?
I am on. Yes, good morning.
Okay, take it away.
Great. First, thank you to the workshop committee for the invitation. It's always an honor to be asked to participate in a National Academy workshop. For those who don't know, ASHP represents 55,000 pharmacists, student pharmacists, and pharmacy technicians. Our pharmacists serve as patient care providers in a variety of settings, including emergency departments, intensive care units, ambulatory settings, all of which see COVID-19 patients regularly and care for those patients. For this 5 minutes or so, I'd like to focus on some allocation decisions as they apply to the front lines. So the next slide will show you some of the considerations that we've already discussed. And it's important for the care providers on the front lines to know how these allocation decisions are made. If you recall, the initial phase of remdesivir allocation and distribution was a learning experience. A lot of frontline practitioners were confused, concerned about gaining access to remdesivir for their patients. HHS quickly changed the process, communicated those changes. The allocation and distribution process of monoclonal therapies has been very transparent. It's based on real-time data. So it's been timely, it's been transparent. It's been equitable to the states and territories based on those data that Dr. Red shared. So it's been a very fair use of consistently available data. They were all reported, again, as Dr. Red shared, from the front lines, from those hospitals. So the process has been extremely well communicated and very transparent. The next slide will be a little bit closer to the front lines. We're looking at those decisions, how they affect infusion sites and hospitals. We heard a little bit about this from Dr. Red. We've heard a lot more about it from Dr. Rosinska in her right patient information. I'd like to spend a little bit more time talking about what hospitals are doing to manage this on the front lines. This includes patient identification, operational challenges, and personnel considerations. For the front lines, there's basically there's several rate limiting steps that would prohibit these infusions from finding their way into patients. But the two most prominent are the drug supply, as Marta alluded to, and then the capacity to infuse. So the next slide, I think we've covered a little bit of this already, but I'd still like to talk through this some. So there are two considerations for identifying patients. The first is the challenge that sites infusing the drug may not be the same site performing COVID testing. So testing may occur at a commercial lab facility, at a health system, at a pharmacy, or other sites established by a state or local health department. And then the infusion locations will vary by state and region. So there's a challenge with rural settings having resources, communication, transportation between sites. Marta also mentioned urban settings. So the other thing is the challenges with testing capacity and testing turnaround time. So because these are time-limited therapies, as we've already discussed, the EUA has an indication for within 10 days of symptom onset. So a person having symptoms maybe for a couple of days before thinking, hey, I should probably get tested, they may wait 3, 4, or 5 days for test results, and now they have a more limited window for infusion. And because of that potential communication disconnect between a testing site and locations that have the ability to infuse, that time, even though it sounds like 3, 4 days should be plenty of time, that referral process, identification process may be a little bit more challenging. The next slide, again, I think this has been covered a little bit, but it shows you what decisions are being made on those front lines. So again, we talked about the two rate limiting steps. If the rate limiting step is drug supply, then institutions are doing what they can to identify the patients who are most likely to benefit from these therapies. So ideally, we have enough to treat everyone who meets those EUA criteria. But we know that because of supply constraints, and again, as Marta mentioned, we've become accustomed to managing drug shortages, and allocations just mean a drug shortage. So fortunately, a lot of hospitals have mechanisms to manage shortages, and this is one of them. It's prioritizing patients. So again, in a setting where the supply is a rate limiting step, we want to ensure that the benefits of these treatments is maximized. There are a couple of resources. There was actually an article published in the journal Nature last week out of Johns Hopkins. It assesses individual and community level risk for COVID-19 mortality. It takes into account sex, social determinants of health, age, geographic location. The panelists have a chat going, and Dr. Kadlec also shared a tool that was developed by the Veterans Health Administration. So there are some analytics and tools to help us identify those at most risk for severe COVID-19 infections and complications. So finding that ideal patient population when the drug supply is a rate limiting step is very important. As far as operational challenges, in the next slide, again, these have been addressed a little bit. So we have a COVID-19 positive patient. So our typical places where patients may go for therapy may not be the best idea. Immunocompromised patients, healthy non-COVID patients, even urgent care settings that might be in a drugstore or in a grocery store, maybe not the best idea for treating these patients. Staff are also stretched thin in many regions. As we talked about, COVID hospitalizations continue to climb. We hit over 112,000 yesterday. So there's still concern over not only the personnel resources, but the resources needed to protect them. So personal protective equipment, there's still challenges with those supplies. Dose preparation is another issue. So these are not simple administrations to prepare. They require removal of volume from a bag. They require admixing several vials. And actually on the next slide, there's an image of Regeneron products, the label. So fortunately, while sterile technique is still required, USP, who develops standards on sterile compounding safety, has actually released some guidance that would allow the preparation of these products outside of what we would typically use to prepare IV products. These are, as I mentioned, complex preparations. The casirivimab and bevimab combo from Regeneron requires 10 mLs of each product. The labels for one of the products from an investigational drug perspective is here on the screen. Preparation may take up to 8 2.5 ml vials, or it may be one 11.1 ml vial. So for those who are not accustomed to preparing drugs like this that are labeled somewhat generically because of the investigational nature of the drug, it can be challenging. There's actually been reports of errors already made to the Institute for Safe Medication Practices, or ISMP. So all of these things are considerations on the front lines for safely infusing these drugs. And this all ties back into allocation, because if these are the rate limiting steps, then allocations may need to be adjusted and sent elsewhere to make sure that patients are getting infusion. So this sounds like a lot of barriers. I'll wrap up with my final slide, which is just the title and my contact information. The good news is healthcare workers, as we've learned during the pandemic, have demonstrated incredible resilience and ingenuity. So I think we're going to hear some great examples from healthcare leaders on the front lines about how they're ensuring patients have access to these therapies. Thank you, and I look forward to the panel discussion.
Okay, thanks very much. Okay, moving along, we have kind of a team presentation. So we have Michael Wargo, who's the Vice President of Emergency Preparedness of HCA Healthcare and the acting chair of U.S. Healthcare and Public Health Sector Coordinating Council, and Mark Jarrett, who's a senior vice president and chief quality officer at Northwell Health. So I'm assuming, Michael, you're going to start and Mark will follow.
Yeah, good morning and thank you for having us today. I want to start just by explaining the Health and Public Health Sector Coordinating Council. Under Homeland Security Presidential Directive 21, this directive allows the private sector to form council by consensus that is exempt from the Federal Advisory Committee in discussions with our government sector leaders under what's called CPAC, or the Critical Infrastructure Protection Advisory Council Act. This gives us the privilege to have frank discussions with our government leaders on a mirage of topics, and it allows us to bring other healthcare organizations together to form consensus, to understand the experience at the operational level, and to advise our senior government leaders on strategies, operations, and innovations in care. It also gives us the privilege to obtain security clearances and have classified briefings from our HHS leadership on various topics. So with this, right before the EAU for the antibodies, I heard from Dr. Kadlik and Dr. Red with a request to bring together some members from the Health and Public Health Sector Coordinating Council to talk about innovations and high-risk areas where we can first deploy some of the monoclonal antibodies out. So today, Dr. Jarrett's going to talk a little bit about the experience throughout New York through Northwell Health System. And then I'm going to speak a little bit about some innovative concepts that my colleagues and I have been working toward for the past few weeks. So with that, I'll turn it over to Dr. Jarrett from Northwell.
Okay. Thank you. And again, thank you very much for the opportunity to speak to the National Academy. It's truly an honor. So what I'm going to do is kind of go over what our experience is at Northwell, and I'll try and do it quickly. A lot of the policies issues really, and were discussed earlier, really kind of hit home with exactly what our experience has been. Can I have the next slide, please, Emma? All right. So the good news is we have treatment that helps many of our vulnerable patients, and that is great news. A offsite will be not only helping the patients, this may reduce the burden on admissions and ICU capacity needs, which everybody in the country is experiencing now. And in reality, this is not a complicated technology. I'm a rheumatologist by trade, and I've been giving infusions for years. This is not that complicated. However, in the setting of COVID and the setting of the other things I'm going to discuss, it has become much more complicated than it normally would be. Can I have the next slide? So this is just a map showing Northwell. For those who don't know Northwell, we're 23 hospitals, 800 ambulatory sites that stretch up into Westchester, all through New York City, and all the way out to the very rural areas of Suffolk County out on Long Island. So we really are urban, suburban, and rural, and therefore face many of the issues. And many of our sites are located in areas that are underserved and people of color. So we really have the equity issue to deal with as well. Can I have the next slide? So our experience since the drugs were sent, we've developed 5 infusion centers, including our children's hospital, because between 12 and 18, we felt that if those children are really complex, have complex illnesses, it'd be safer to do it in the setting of the ED. And the other sites are freestanding sites. We have a 6th plan to open up in the next few days. Actually, the slide I didn't update from last night, we've done about 360 patients so far in our centers, mostly with the Lilly product. We're just starting now with the Regeneron product. 2 patients we've also done as inpatients. These were patients who came in for non-COVID issues, were still in the hospital, and then developed symptoms of COVID, either because they were still incubating it when they came in, or unfortunately, they might have caught it from a visitor, although we're reducing a lot of visitors. Okay, the next slide. So in our experience, what we're looking at is we're not getting enough patients, and we actually still have supply. We want to be in the situation, honestly, where the demand is higher than the supply, because then that means we're really giving it to everybody. And there are a number of reasons for that, and I'll go into that in a few moments. But we're trying to figure out different ways of giving it other than the infusion centers that we set up. We obviously could not use our standard infusion centers that we use for either rheumatology or even chemotherapy, because all of these patients are in a very highly infectious state, and therefore they need to be in a very COVID-contained type of situation. So we're really looking for other areas. So we're expanding it now to our ED treat and release patients. So if we had an 80-year-old who came in because they had mild symptoms, but they were very concerned, and we can turn around the test quickly, which with our laboratories, we can turn around the PCR test now in about 4 hours if necessary at the hospitals. We might keep them there and then treat them and then send them home so that it does not overburden our infusion sites, and clearly, especially for the elderly, and also for those in underserved communities who use the ED as their primary place of care, it means that they don't have to worry to get someplace. And we'll talk about that in a moment. We're starting to plan to gear up to do this in long-term care facilities, with the understanding that hopefully in the next month, if we start vaccinating the residents of the long-term care facilities, maybe actually the next week or two, that this may be a temporary thing that maybe perhaps a month from now goes away. We've looked at home infusion. We're setting up to do that. The problem with home infusion, and we'll get to staffing in a second, it's very labor intensive. You can't do very many people a day. You have to travel there. You have to bring the equipment. You have to get the patient set up, do the infusion, watch the patient, and then travel to the next place. You can't do very many people a day that way. We're really looking to save that for people who really are homebound or in underserved areas where they have no way of getting to the infusion center. We've explored paramedics. Our paramedic people already work with telemedicine with us in doing care in the home for heart failure and other conditions. However, again, that's a resource that that we have to be very careful with the surge going on, because we learned back in March and April in New York that when the surge was bad, the wait times for calls where it's getting too long for the paramedics and EMS in New York metropolitan area, and we can't have that happen. I will tell you, we've only had 4 patients that required admission to the hospital, none due to reactions. They actually had within 24, 48 hours progression of their disease, which means probably the antibodies they were further down the road in terms of their course. But so far, none of the others have, which is a very good sign. We had a few patients go to the ED because of some local reactions. All were treat and releases and went home. Can I have the next slide? So what are our barriers? As I said, you need to do this in COVID-contained areas. Also, our EDs are very busy. It's not an ideal place to do a lot of them. We had to set up a call center to triage, and this gets to the issue of if demand starts to outstrip supply, how do we decide on triaging? And we're looking at algorithms and other things, building an equity to that. We have a call center where people can literally call up and make their appointments. But really, it's also partly finding candidates for infusion. We have provider referrals. We've sent out information not only to our 4,000 full-time faculty, but to our 10,000 voluntary faculty in our system with all the information of how to make an appointment, when to use the drug, all the information about it, so that hopefully we get from all of our providers more referrals. We're looking into the issue of public advertising. We were very hesitant to do that in the beginning because we were afraid we would outstrip our supply. At this point, we really think we may gear up for that. I will tell you another problem is we've had the fear that it's an experimental drug. We've had a number of people who came and then when they heard more about it, decided that they were afraid to take the drug. So we're really looking now again to do a pre-appointment education process, perhaps even with a telemedicine consult. If for people who have concern, quick consult could be with a nurse practitioner, could be anybody who's well trained to explain it so that A, we don't take up a slot, and number 2, we have people more comfortable. Our other big problem is obviously transportation, especially in the urban areas. In rural areas, it's kind of easy. Everybody has a car, and although there are homebound people, people can travel. If you look in New York City, Many people do not have cars and they're dependent on public transportation. And that's an issue of getting them to infusion centers because clearly we do not want them on buses or trains when they're this infectious. So we're trying to figure that out. We've looked at vans. There are some issues with that. We've even looked about bringing this to certain communities in using blood bank mobile vans because they already have the chairs set up and everything else. Again, we're trying to figure this out if this will really work. Plus, with the blood supply being low, they're using all those blood bank vans now trying to get more blood, especially around the holidays. So again, it's scarce resources going on. Can I have the next slide? And this is probably the biggest issue. This is the perfect storm for staffing issues. We have a surge of disease in the hospitals. We are in Northwell in our 23 hospitals. We're back up to almost 900 cases in the hospital, where during the summer we were down to 40 or 50. We now need lots of staff for vaccination. And this especially even for oversight of nurses on the vaccination sites. And this is even just doing our employees. When we go to roll it out regionally in our area to the general public, we're going to need a huge number of staff to be able to do that. Infusion staff themselves come from the nursing pool, and they have, and therefore that is a problem. And then, as I said, it's a problem with EMS. So one of the things we are grappling with is literally how do we staff these centers and not use our EDs, which are already overwhelmed with COVID patients, as a place to treat, and there is no room, quite frankly. We're holding patients not infrequently. Plus, we have to be careful. We don't want to turn the EDs into COVID sites because then people who have heart attacks and strokes, like in March and April, will not come to the hospital. They'll be afraid and we'll have a problem. Can I have the next slide? So in summary, it's working. We need to ramp this up even more. This is a resource we need to get to our patients. It will ease the burden on the hospitals, but the devil is in the details. This is not easy. And I look forward to hearing from others and hopefully getting more information that we can bring back to ourselves so that we can work to get this out in a fair way, an equitable way to as many people as we can where it is appropriate. So thank you.
Okay, Michael, are you back?
I'm back on. I think you need to permission my video.
Okay, we got your slides up.
Great, thanks. So we began with the introduction earlier. So Emma, you can go to the next slide, please. Thanks. So as I alluded to earlier, once I heard from the ASPR office, the Health and Public Health Sector Coordination Council brought together roughly 30 health systems from across the country, from large academic centers to national organizations like the one I work for, HCA Healthcare, and some colleagues such as Ascension, to rural community hospitals and critical access hospitals. One of my co-chairs at the Health and Public Health Sector Coordinating Council, Dr. Jim McClory, who works at Riverside Doctors Hospital, brought on board some members of his team to discuss this. And the discussion that we had was really mission focused toward reducing disease progression and the rate of hospitalization for Operation Preserve ICU. The aim that we had was, number one, to save lives and improve the patient's quality of life through this infusion. Secondly, to reduce the volume of COVID admissions on the acute care system, which we heard from Dr. Jarrett and others that we've been overburdened for many months now. And part of this discussion is how can we innovate outside the acute care setting into the community, either through mobile assets or other innovations. You see the reduction of ICU admissions, and they certainly to reduce clinical impacts on target populations. And I'll speak a little bit more about this because this has a compounding threat to us that when our essential or critical personnel, first responders, first receivers, critical infrastructure personnel are impacted by COVID and taken off the front lines, we have that ripple effect on our communities. So there's a targeted discussion that we'll present to you as well. And then certainly increase the access to the monoclonals into the community. Next slide, please. So first, the targeted at-risk population. There were two focuses that we had a discussion. For, as I mentioned, the first responders, or that critical infrastructure and personnel segment. Part of this was, can we create distribution channels and public-private partnerships locally with first responder agencies that we can, they're going through prioritized testing on the streets of the community to ensure that those first responders that have a confirmed case of COVID are taken off the front lines so they don't further expose others. That's also a population of the United States that typically meets much of the criteria, comorbid factors such as cardiac disease, diabetes, obesity. Can we target distribution to those frontline providers and educate their leadership and their colleagues on how to do the infusions within their agencies so that we can give a direct line access? So this is a conversation that we had yesterday with a number of EMS leaders, and a small group of us that meet every Monday on monoclonals have been discussing to put together a proposal toward. Second is congregate living centers, such as long-term care facilities, skilled nursing facilities, and detention centers. The University of Pennsylvania has launched a program in partnership with the state and other health systems targeted toward skilled nursing facilities and long-term care. I'll talk a little bit about the barriers, but they had great success in their infusions in the sense that they're not going in necessarily to infuse one person at a time, but they've innovated to bring those within one congregate living center into a community activity room, set a few of them up, and do multiple infusions at one time with the oversight of one or two nurses and support staff. So they're innovating on how we can scale this greater than one patient per one provider within those settings. The next, Dr. Jared talked a little bit about one of the concepts that we proposed of how do we increase the equity of distribution? How do we get to rural communities or underserved communities, or those communities where access to the infusion is difficult? One of the concepts that we talked about that he referred to was reversing the process of blood donation and potentially partnering with American Blood Center or the American Red Cross that have mobile blood donation vehicles or mobile blood donation resources to go into these centers where the patients are and advertise and bring the service to them. This is a concept that I know is small scale, such as the one in Long Island, but it's something that I believe we should explore further. This also includes community paramedicine models. In some of the community paramedicine models, those staff that are assigned to community paramedicine aren't the typical 911 paramedic staff that respond on those calls, but they work for agencies or they work for health systems that do a service similar to home nursing care, but they do it targeted to certain populations such as CHF and diabetes management to reduce our readmissions. Can we educate and train those individuals on providing this service either at mass community infusion centers or through mobile integrated health and an ambulance going to the high-risk patients or these community centers? All concepts that need further development. The last thing that I'll really mention before we get into a discussion is alternate infusion center providers and locations. As I sit here in Nashville, and it's a party city, much like Vegas, or it was, we have a lot of infusion centers for those that might not be feeling so well after the bars the next day. They're staffed by nurse practitioners and physicians, paramedics and critical care nurses that do IV infusions to recover from the night before. Can we look to those services that don't have a great volume of business and provide them a partnership with a local CVS or Walgreens that might have access to this, and develop a system and a process that when we identify a patient in the community, we refer them to one of these infusion clinics who then gets access from one of the other partners that we have to provide this. All of this aimed at reducing the demand on the acute care setting. We certainly want to reduce the volume of folks that we push to hospitals that get further exposure, as well as challenge their staff. So we look forward to greater discussion on some of these concepts as we go forward. Next slide, please. The last two collaboratives that we had, both with the EMS leaders across the nation, as well as the various hospital systems and infusion clinics that we've partnered with in our discussions, brought up these barriers, and many of them, this isn't the first time you're hearing about it. But one of the biggest things that we've heard from both groups was awareness of this therapy. We heard about the president, we heard about the former New York mayor that received this cocktail, the secret cocktail, when they came down with it, being the monoclonals. There's not much media out there that talks to the general public and the general medical provider population that explains how to access the monoclonals, how to develop protocols for this, what it really means. And we really advocate for a public-private partnership to increase the awareness out there. Again, the limited protocols and access to therapy goes back to that referral base. Do we have awareness within our health systems and the broader healthcare community on how to access the monoclonals, what the appropriate therapy sites or environments are, and how to direct their patients toward that? Testing availability and turnaround time, we talked about that quite a bit, so I'm going to go over that. For our pre-hospital community, the community paramedics, paramedicine programs, the mobile infusion clinics, or the visiting nurses, the time on task is a real issue for them. As Dr. Jarrett talked about staffing, we're pulling much of them currently off of 911 calls or other programs because there's a lack of education availability out there for community paramedicine programs on this. And for our infusion clinics who are dealing with our chemo patients and those at-risk populations, we're trying to pull them into the community to administer this. So the time on task, roughly 3 hours per infusion, is a real challenge for them. We talked quite a bit on the lack of clinical data and clinical evidence, and we really truly believe there is a need for a public-private partnership for a common database on the infusion that has done, the exposure and the evidence of the outcomes of these patients that we can share amongst the community and the academic and scientific community so that we can see the effectiveness and how the therapies are working, which practices are working, how access to care is working. So Dr. Jarrett and I are going to continue that discussion with our partnership calls on Monday and try to form a private sector component that shares data on this sector. Scope of practice was a big discussion yesterday when we spoke to many of the state EMS executives, the directors of EMS in many of the states and the leadership across the country. In most states, particularly under the emergency declarations that exist, the scope of practice to allow or to adjust the scope of practice in states for paramedics or EMT advanced with the ability to do infusions exist. But there is a lack of education toward that community. So that's a need and a gap that we certainly have for that. They brought up the environment of practice. In many of these cases, we're looking to infusion centers, we're looking to community convention centers, such as the one that was stood up in El Paso to have mass infusion clinics. The environment of practice is something that paramedics and our pre-hospital providers are accustomed to, adjusting their ability to deliver care in various settings. So this is where we have an opportunity to continue to educate, change the scope of practice, and advance our ability to provide access to the therapies there. I heard quite a bit from these agencies on the lack of funding for sustained operations. Because this is a new ask of them, many of them don't have the additional staff or they're hiring additional staff for this. And in some cases like Pennsylvania, they're using state-funded grants to produce this program, which is a collaborative across the state or a region of the state. The big question that they have there is, how do we do this for the long term? And there is reimbursement that exists with this, but that model and that business function has not been well developed for them. So I think a better understanding of how to access the reimbursement, when it applies, and what that looks like can really help our organizations. And then lack of regulatory guidance and awareness, particularly for the pre-hospital community. What does it take to get regulatory approval for them to administer the monoclonals, whether it's at the patient's home, whether it's in a community center, or one of these other modalities that we spoke about. So I think there's some education that we can partner on there with them as well. Next slide, please. So I'll conclude with this slide, and these are really opportunities for further collaboration, starting with the private sector, but certainly in partnership with our public sector, our government agencies. Dr. Jarrett and I, as I mentioned, are collaborating on the Infusion Program Leadership Collaborative every Monday. We hope to expand that out to our pre-hospital leaders and anyone else that's interested in partnering with us. And it's really just an open discussion of best practices, challenges, and opportunities amongst the infusion centers that we have access to. The public awareness and media campaign, Dr. Jarrett spoke about that as well. Within your organizations, within your professional and academic trade organizations, we really need to get the awareness out, educate folks on this. We talked about the target awareness to providers, particularly the critical infrastructure. That's an area that we hope to develop with you. And then the last few things really come together in developing automated alerts, whether it's in your electronic health record system that alerts both patient and provider that this person is tested, they received a positive test, they meet criteria, and then that triggers a sequence and a chain of events that alerts pharmacies, whether it's inpatient pharmacies that prepare the infusion, community pharmacies, or other resources. It gives scheduling and access alerts to that patient on where to go, when to go, et cetera. These are systems that we can partner toward. And then it was mentioned before, the integration of telemedicine. This was a big discussion on Monday of how can we partner with the larger telemedicine companies that are managing these patients in their home, creating awareness for them that this program exists, and helping them build a referral base for us to get more access to the monoclonals into the community. Next slide. So with that, I'll say thank you on behalf of myself and Dr. Jared and my colleagues at the Health and Public Health Sector Coordination Council. And Kent, we'll turn it back to you.
Okay, thanks so much. Great presentations by everyone. We've got about 15 minutes for some questions. I'm going to start off, maybe Michael, just to kind of key on one of your aspects having to do with barriers of care. We've all seen, I've seen it in my community here in rural northeastern Pennsylvania, where there are kind of episodic kind of pop-up testing facilities where you see, 6-hour lines of cars just passing through to get swabbed and off they go. Many of these people fall below the safety net. They're not connected with an integrated healthcare system. They may or may not, well, I guess most probably have cell phones and they get the results, but they're not really connected. And so when I was listening to your talk, I'm trying to see how do these people even get captured? If they are the the people who might be the best candidates for infusion therapy. Have you and your team thought about this or had any discussions? How we, because on the one hand, people who are plugged into primary care or integrated healthcare system, that's a whole different construct than many of these other people who are, quite frankly, getting a lot of tests.
We have, and one illustration that I'll provide is in El Paso, where we collaborated with the Border RAC and brought all the 3 major health systems, 7 hospitals together in the heat of the surge down there. And as they developed the protocols for the community infusion center there, they developed alerts within the health systems that when you came in to either a hospital, a care now, an outpatient testing clinic, or community center, they assessed you for inclusion criteria for the monoclonals. And if you met that inclusion criteria, there was a trigger built into the system that when you were notified of your result, that you also had a direct line to physicians that can write the script and provide a resource or schedule you into the convention center for an infusion. Same process we described on a call with the infusion centers at large, that we need to develop this inclusion criteria at the point of testing. When they go in and they're screened for risk for COVID, well, let's screen them for the inclusion criteria. Let's build that and even partner with the large laboratory systems such as Quest Diagnostics that in their system, if a positive result is found, can their system also cross-reference that criteria? And if so, that indicator, when it goes to whoever, the patient itself, if they haven't been in a health system that says, hey, here's you tested positive, you are within the inclusion criteria, here's a local resource that you should reach out to for further information on monoclonals. That is one system in a partnership that we advocate that we should help develop.
Okay, great, thanks. For John Red, I actually have 2 questions. One is probably easier than the other. You spoke about sort of the differential in terms of kind of number of patient courses, allocations for states versus for the feds. And we know we have a number of federal agencies. everything from large, the Veterans Health Administration, the DoD, Indian Health Service, to smaller, Bureau of Prisons and other things. So my question is, in terms of policy, I understand, and I'll get to this in my second question, in our country where we have a kind of federalized, states have primacy in many things, but for the various federal agencies, do we have uniformity in terms of allocation practices and how patients are identified? And I mean, is there guidance or policy at the federal level that at least subsumes all of the relevant federal agencies where this is concerned?
Yes, thanks. And the answer to that is yes. We do have separate systems for the federal systems which need product. The main difference for us is that their data are different. So we don't have. I mean, I cannot claim that we have precisely the same data for sites such as Indian Health Service, which was the matter of particular attention very early. And so I would say the answer is yes. We have a separate way to account for the federal sites that they, for lack of a better term, are a state. I'm doing air quotes here in terms of the allocations. Let me say one separate thing, especially with Dr. Berwick's question about American Indian, Alaska Native populations. So we've been very, very concerned from the get-go about the concentration of risk factors, as well as, if you just look at the data, with cases including large clusters in American Indian, Alaska Native populations. So when I say Indian Health Service, in terms of, I'll say two things. When I say Indian Health Service, that very deliberately includes tribal settings as well. So in the IHS world in which I've spent most of my career, ITU is Indian, Tribal, and Urban Centers. So when we put Indian Health Service allocations, they go to all those centers. And that was IHS, that was their choice and was socialized with tribal leaders. The second thing I'll say is in terms of our pilot programs, one of the first demonstration projects that we did, in fact, the first one that we approved, was to American Indian, Alaska Native settings. And that was the 1,000 doses. That was the first group that we thought of, primarily because we know that that's a broadly distributed rural system that has infrastructure at the other end. So very, very amenable to demonstrating feasibility of these techniques. And I'm happy to say, I'm not remembering at the moment if it's 8 or 9 locations in Alaska, but those demonstration projects have gotten product to Cherokee Nation and to Alaska. Those are demonstration projects that are somewhat separate. But in addition to that, we've gotten around 1,500 additional doses out to AIAN sites. And Bureau of Prisons, DoD, Veterans Health Administration are all taken care of similarly.
Is there a reason that the data that you get, I mean, it sounds like from your presentation, you have reasonable degree of confidence in the reporting from the non-federal healthcare facilities. Is there a reason why within the federal government, I mean, you mentioned that, your confidence perhaps, or the completeness perhaps of some of the data coming from the federal agencies is less optimal?
Well, I wouldn't say less optimal, actually. It's just different. So, for example, the concept of confirmation is not embedded. I actually was, I'm happy to say that I was part of the development of the system that IHS still uses for syndromic surveillance of influenza, which we developed during the H1N1 pandemic, and they have used that infrastructure to lay on syndromic surveillance for COVID-19 cases. So I would actually say the data are different, neither better nor worse, just surveilled somewhat differently, and that was very hard to modify, frankly. There are separate federal data systems for VA, for example, that are very difficult to modify.
Okay. So to my second question, so we heard from a number of the presenters today, really what amounts to be a series of best practices, either that are in place or evolving. Recognizing that, from your presentation, the federal government is basically serving as a supplier, and to the states, with, I guess, suggestions on what to do, i.e., sort of guidelines, but then it's left to the states. We've heard some have allocation boards and other things. What are your thoughts in terms of at least allowing for the federal government, state government equities? What are your thoughts about better publicizing best practices that are resulting from these, I call them demonstration projects, pilots, works in progress that, quite frankly, if you look at all the points made by the various speakers today, taken as a continuum, there's a lot of good stuff there. And so how does the federal government try to, without overstepping its role, to try to really, impress upon the states the value of some of these approaches, recognizing, there's different geographies, different population distributions, different socioeconomic distinctions, et cetera, but to go on your point of fairness, transparency, efficiency, et cetera, et cetera.
Well, thanks. And so I have several comments, and this is some of the issues that I've been taking down in my notes here as we go. So the first of all, in terms of our external affairs program, it's multifaceted. So some of it is traditional. I just got a request for an interview today with USA Today, for example. I mean, so we do those more typical outlets, but a lot of our outreach actually has been with provider communities and with patient communities as well. So it's been very difficult to move the needle in this setting where states are just overwhelmed. And we really, I would stipulate that places are overwhelmed, both clinical sites and the state governments themselves. And we're sympathetic with that. So what we've tried to do is to take as much burden as possible off of states if they would like to have that burden taken off, while maintaining state decision-making in the process. So I'll give you a couple examples. Some of these are actually going to be coming up. This is something of a 2-hour sneak preview. We have our normal outreach calls this afternoon. But we have a public-facing HHS Protect website that we're offering each state, which similarly to what Marta mentioned about the NICA website, which is useful. That show, the NICA website shows locations of infusion centers. We're giving states the option to either opt in or opt out for us to host on the public-facing portion of HHS Protect a clickable map that will show providers and citizens where the product has been delivered. And so far, we've got, I think the count is 26 states have opted in for that, and many of them have been quite keen to share. So that's one example of trying to get publicity out. We're working to make sure that people would be able to end up with that information should they Google search, things like that. So to make sure that those listings are actually literally out there. We've also got, as I mentioned briefly, the demonstration projects, but we're starting something this week that we're calling SPEED, which is special projects to, special projects for equitable and efficient distribution. And I want to mention 2 of those that we're starting. These are separate from the state allocations. We have not, we haven't reduced the state allocations. This is in addition to them. So we're working on 2 broad demonstration projects. The first is with pharmacies that serve long-term care facilities. And we're actually, as of today, when we announce the numbers, are going to be sending, sorry, I've got this here in my 6,360 doses to a total of over 300 locations that are going to be able to put product in pharmacies that serve long-term care facilities ahead of time. So that's a way to have it pre-positioned where we know outbreaks are going to happen. And then, so that's for, I'm doing air quotes, home infusion in long-term care facilities, which we mentioned before is what we think is an extremely valuable strategy. And then we're doing additional speed initiatives. I'll say just one more that we're really excited about is we've been working directly with federally qualified health centers. Some of them have wanted to give this type of product and some have not, but we've been communicating with them, and we're already delivering in Los Angeles County, for example. So those are some examples, Kirk.
Okay, thank you. Let me quick pose a question to Dr. Jarrett. You know, you're obviously experienced in your professional practice with infusions and rheumatology, you know, and in your role in an integrated healthcare system, you have a variety of facilities and people and staff, et cetera. As we think about, you know, and we've heard a number of the speakers today talk about, well, how can we augment? Who can we recruit? Who can we hire? You know, what sort of systems can we bring online to get broader utilization? You know, also, I think about these things are not necessarily benign. You know, I mean, presumably most people do fine with these infusions, but what are your thoughts in terms of trying to stand up a multiplicity of, you know, I'm going to say medics. I don't mean medics, but sort of augmentees, you know, to provide infusion therapy where needed and appropriate, and the potential risk for perhaps problems.
So the way we've done it is in a couple of ways, and it kind of matches how we did staffing during the major surge in the spring. We may bring in an expert infusion nurse to oversee other personnel in the infusion center and act as the clinical lead. They have the experience. They know what to do when things don't go well. We have all the proper, we've actually put a whole cart in with not only anaphylaxis equipment, but other equipment, because these are very often older people who have multiple medical problems to begin with. So we've done all that. And what we've done is use them as, so to speak, extenders. So we have one supervising other staff who clearly regular nurses can give an infusion, can put an IV in and run an IV in, but this allows the opportunity to have that expertise locally. We've also tagged it where there is a medical question about whether it's right to a expert physician who, even if they're not on site, by telemedicine can quickly do consults about situations that's going on. So it's a matter of buddy systems so that one person who really has that expertise can spread their wealth of knowledge, and then after time, other people become expert at it, but from their infusion experience, because that's really kind of critical, because thankfully things rarely go wrong, but having done it and having had it next to my office, when they do go wrong, it is a little frightening, and it is very time sensitive because people can drop a blood pressure quickly, things like that. So you have to have the appropriate equipment and at least somebody who has that expertise on site to know what to do specifically in those situations.
Okay, great. Well, I think we're at time for this section. I want to thank all the presenters. I wish we had more time, but I think it was a really interesting and useful session. I'm going to turn it back over to Harvey to close out this part of the activity.
Thank you so very, very much, Kent. This was a terrific overview session. I want to add my thanks to John and to Marta, to Michael Gagno, Michael Wargo, and Mark Jarrett for their excellent presentations. You've given us a fabulous start. We're now going to take a break. This is an opportunity for lunch on the East Coast, break on the West Coast, and anything else in between that you choose internationally as well. Our plan is to reconvene promptly at 1/4 the hour. So we will look forward to seeing the panel for the next session at 1/4 and to having all of you rejoin us at that time. Thank you again for your participation. See you in a half hour. Greetings and welcome back, everyone. It's a pleasure for me now to invite John Hick, the moderator for our panel of on-the-ground perspectives, to take over. I look forward, as I know we all do, to the hour-and-a-half discussion from the range of perspectives that we're about to hear. So with that, John, over to you.
Great. Thanks so much, Dr. Feinberg. It's a pleasure to be able to moderate this next section. We'll have 45 minutes of presentation of on-the-ground experiences in the allocation and administration of the monoclonal antibodies. So I won't spend a whole lot of time with introductions, but just to say that we're excited to hear from a panel with a lot of pharmacy and infectious disease operational experience with the monoclonals. So without further ado, we'll start with Jeff Gumprecht, who's an associate professor in infectious diseases with the Mount Sinai Health Systems in New York. Jeff, thanks so much for taking time today, and thanks to all our panelists for joining us today and sharing the information that is so needed to help inform these discussions. Jeff, you may be muted. If that's a real background, I want to be there, but we're still having trouble with your audio here. Jeff, still not hearing you. Wonder, would you be able to call in on the landline number? And I'll move down on the speaker list here, and we'll come back to you in a couple minutes. So in the meantime, grab your surfboard. So. All right, thank you, sir. Eric France is unfortunately not yet on the line with us, but we will move on to Mohammed Karbat. Eric is here. Eric, thank you so much. Eric is Chief Medical Officer for the Colorado Department of Public Health and Environment. And Eric, thanks again for taking time.
Thank you, and I assume you can hear me, John?
Yes, perfectly, although I really like the background that Jeff had better, but that's okay.
That sounds fine. Well, I'm just going to go ahead and share my screen here where I have some slides, if you would. Hello, everybody. My name is Dr. Eric France. I am the Chief Medical Officer for the Colorado Department of Public Health and Environment, excuse me. And so I just wanted to talk to you a bit about the work that we've done here. November 10th, of course, was the first EUA, and I think within a day or two, I was learning that doses would be arriving the next week, some 1,600, if I remember correctly. And I'm almost ashamed to say it was the first I knew it was coming, or that we would start getting to work on it, was the day that I saw it in the news that night. So we quickly wanted to build something that was really focused on a number of principles. The first of which, apologies as I just move my slides here, was that I wanted to be sure that whatever doses we were receiving were distributed across the state. The system of sending it to hospitals as created by HHS meant that we would concentrate the doses to certain areas, and that didn't feel equitable. I wanted to be sure that whether you were in a small rural town or in the Denver metro area, you would have access. We also wanted to be sure that if there were certain parts of the state that had higher risk, higher number of cases, or maybe people with increased risk factors, that their doses should go preferentially to them over another area. And we were assuming too that there would be fewer doses than potentially eligible persons. And so we had been working since the summer on doing a random allocation tool that would assign somebody through a lottery and a system whether or not they would actually receive some novel therapy in the future when it came to COVID. So we dusted off that work and put it into play for these therapies. I looked to a part of the state health department that tracks the existence of hospital staff and physician staff across the state. They know where our doctors are, and I asked them to help me in this effort. So they created 21 different catchment areas, and then they used some of their mapping tools to identify where would be a central spot for which in their catchment area, they would not have to drive more than 90 minutes to get there. And so you'll see on this map, the black lines are 21 areas. The blue H represents the hospital or health system within those catchment areas that is centralized, and the polygons show you where people were driving from to get to that center. So this helped me say, okay, well, here I have potential partners that can help provide these infusions for these therapies across the state. This work was also successful in that we had more than 98% of all the residents of Colorado being able to access one of these sites within a 90-minute drive one way from their home. And so this at least gave us a starting point to think about where the catchment areas are. The next question is, well, okay, if I have 21 catchment areas and I'm getting 1,500 doses, or how do I distribute those? What percent does each of these catchment areas get of my weekly allotment? And to do this, we said there are really two factors we should consider. What is the risk level of any given catchment area, and what percent of our total COVID-19 cases of the previous 2 weeks occurred in those catchment areas? And we simply multiply the two and divide them by 2, multiply them and then divide them by 2 to give me a rough estimate of what percent of my allocation should go to a specific catchment area. We built some modeling. We knew there were certain demographic indicators that would be associated with increased risk. And from our modeling, we identified certain factors: age, percent of FPL, Hispanic ethnicity, male. These were all considered important predictors of risk for COVID-19 in our modeling. And we used them, therefore, to assign risk across our state and then into the catchment areas. Here you see our 21 areas, the population size for each of them. And if we looked at the prior 2 weeks about total cases in the state of COVID, what percent of them occurred in a given catchment area? And if we look at a total burden across the state of risk, what percent is assigned to each catchment area? And then what allocation, if I multiply and then divide the 2, should I be sending to any of those given areas? If you look down to the fourth line from the bottom, you'll see Pueblo, 9% of all cases in the prior 2 weeks happened in that area, and yet they only had 5% of the risk burden. So the actual allocation would be 7.3% of the total doses I receive. Contrast with the Denver area, where the risk burden was a little higher, and the risk burden therefore raises the total allocation that would be sent for them. Of course, as I mentioned, we have this medication random allocation process. We borrowed the REDCap system from South Carolina and built it here. A series of questions that the providers have to fill out at the infusion centers or in their clinics. And if somebody qualifies, they click on next page, and then they learn whether or not the patient has been selected to receive these therapies. At this point, our number of therapies far outweighs our population that wants to receive this. And so our odds are 100%. We still wanted us to use this system for the future potential that we might be at a place where there are less doses available than people ready to receive it. Our challenge is clearly we need more infusion sites. We know that standing these up has taken time, and actually we're recognizing that maybe our random allocation should be based on infusion seats rather than the therapeutic doses available to us, because we'll have much fewer infusion seats across the state than the doses that are being shipped to us. That's been quite a challenge. And attached to that challenge is that I've been hesitant to spread the information far and wide to doctors and people in the state about this therapy, because they will certainly overwhelm with the requests, the 22 sites that we've identified. We have another 10 or 15 that are in the process of saying yes or no. We'll work with the new speed effort that I think is underway through the HHS to identify infusion sites. We have a number of sites saying no thank you. Their hospitals are too busy and they don't have enough nurses. Our children's hospital was going to be the organization overseeing it for kids, and they said there's no randomized data on safety or efficacy of children. We, like other states, will not do any children. So none of the 12 to 17-year-olds eligible are going to be offered that. And of course, there's an impact on state resources. I've been having to pick up a project manager, a data person, a communications plan, my work, GIS, REDCap programming, all of this unplanned for at a time that we're busy trying to do vaccination programs. So it's been a surprising arrival and burden, and doing the best that we can to build based on the principles of geography, equity, and access. Thank you very much.
Thanks, Eric. That's excellent. Can I just ask a point of clarification? We'll hold all questions otherwise till the end of the presentations, but how does your system for the lottery, how does that tune the allocation percentage to the available product?
So our plan has been to make an estimate on the number of people who are ill every week, what percent of them meet the criteria of high risk categories required in order to be eligible for it, and therefore come up with a rough back of the envelope estimate of the number of people who are potentially eligible. And then from there would be interested, we make another estimate there, and then just compare the number of seats or doses we have at infusion centers with the demand, and then we set an odds within the software itself to set it, if that makes sense.
Excellent,
So
thank you.
Not rocket science, and it's not super accurate, but it feels better than if we just did a first come, first serve approach.
Absolutely. No, thanks so much for the clarification. And I see Jeff Gumprecht has moved inside from the surf, and we'll try him again here and see how things go. Jeff?
No.
Getting a little better. Initially was a little staticky, but you're starting to sound better. Go ahead. Oh, and now Jeff seems to be frozen.
Here.
Jeff, your audio is really broken.
Sorry.
That's okay. You've gone from frozen to the surf and back again here. So try one more time here. Let's see.
Can you hear me now?
Yes, that's better. Thank you.
Oh, good. I think I have a local internet problem. I apologize. So I thought maybe the most valuable thing I could do would be just to describe the nitty-gritty of our process at the Mount Sinai Medical Center. We've been very concerned about inequalities in healthcare distribution, which really have been stood in relief by the COVID epidemic and the importance of untreated comorbidities. And so briefly, our system is we have an email inbox and we have a telephone number with a call center, and all inquiries, both from providers and from patients, go to a research coordinator nurse. And she does an initial screening from a script. And she then, if patients are appropriate, she then proceeds to refer the patient to a televisit by an infectious disease consultant. The telehealth visit completed, the ID consultant reports the case to an approval committee that's nameless. And if the approval committee agrees with distributing the drug, the monoclonal, to the patient, we then schedule in Epic with our therapeutic infusion group to provide the drug. Generally, we try and do this whole process within 24 hours. The process is running pretty well. We're fortunate that we had a small infusion center for after hours and emergencies with 6 chairs. And so we've committed that to COVID. All the staff in there look like neon highlighters. And so far, the process has gone quite well. What's unresolved, and I haven't heard much discussion, is part of the EUA is a 7-day follow-up. And we're still trying to figure out the best way to do that. Particularly, we know that some patients will progress in their illness despite the infusion of a monoclonal. We'd like to drive those patients back to be monitored by their primary care providers. We're dedicated to using the emergency room as a source of patients because we may be able to schedule them and that patients may be able to walk directly from the ED to our infusion center. It's in the same building, and it's more equitable than providing monoclonals to patients who have very aggressive and on the ball primary care providers. And that is a different population than some of our uninsured and unengaged patients. So that's a quick zip through the entire process, and I'm happy to entertain any questions.
Great, thank you, Jeff. So glad that your internet allowed you to continue there. We're subject to other forces than when we're together. So just a quick clarifying question, if I may. What are the allocation criteria that allocation committee is using to decide yes or no? And understanding right now, it's probably not having to be very restrictive or very strict, but what's the tiering that you all are using?
So, so far, we have not had to be very strict because our supply is greater than demand, but we also have a fair amount of experience with convalescent plasma, which we know is an also uncertain intervention. And we're convinced that the immunocompromised patients, even though we're not provided hierarchies, officially, we understand that our small experiences that hypogamma patients and immunocompromised patients probably are the most likely to benefit. And then we're just looking for the oldest or the most number of comorbidities. And so that's really how we're proceeding. And it's been useful to have a protected and nameless committee, because some people become quite adamant and vociferous about their entitlement.
Absolutely, no, a huge issue. Well, thank you so much for those initial thoughts, Jeff, and I'm sure we'll be back to you with some additional questions during the discussion session. So moving along to Mohammed Karbat from the great neighboring state of Wisconsin, and the Vice President of Pharmacy Services and Health Research at St. Mary's Hospital in Madison. And Mohammed, thank you so much for being here today. And I saw that the Public Health Department had to issue a admonition against cannibal sandwiches in Wisconsin, raw ground beef and raw onions on bread. Any comments on that also?
I'm unaware of this order now.
All right, we'll just talk monoclonals then. Thank you.
Yeah, thank you. Thank you. And my pleasure to be here with you guys today and to walk you through our journey here in Wisconsin when it came to the use of the available monoclonal antibody products. So just like my colleagues shared with the group, these products offer some promise for COVID patients, but at the same time, they come with operational and logistical challenges as well. So here in Wisconsin, when it came to the use of these products, we looked at them from two angles. On one hand, we wanted to decide how will the product be distributed across the state. So that was a state mandate in a way, that they need to come up with a framework for the distribution of the product. Once it arrives at a health system, how is it going to be given to patients? Will there be any further prioritization and so forth? So these are the two parts, and I will walk you through each briefly. So let me start with the state distribution. In Wisconsin, the Department of Health formed a committee, State Disaster Medical Advisory Committee, SDMAC, And this committee has a subcommittee for therapeutics. So the subcommittee for therapeutics began to meet on a weekly basis and then twice a week when these products, when the EUA became imminent, and of course, when the EUA was issued as well. And the framework that the state of Wisconsin came up with was that we will look at the disease burden in every county in the state by looking at the number of COVID positive patients in each county for the past 7 days. And then we also used an adjustment using the Social Vulnerability Index, SVI, for the counties. The higher the SVI, the more disadvantaged the county is, and there will be a multiplier to allow for more doses for those counties. So based on this formula, the number of doses given to the state, which was about 4,000 doses, was then split accordingly between the different counties based on the prevalence of COVID-19 in every county, as I mentioned, with the SVI adjustment. And then in this framework that the state came up with, then they said, once we know how many doses will go to every county, we will then divide it between the hospitals in every county based on the number of COVID-19 admissions over the past 7 days in each hospital. So they looked at the number, some counties have one hospital, some counties have multiple, and the state decided to come up with a framework to divide the number of doses across the hospitals based on COVID-19 admissions at every hospital. So that was determined on the state level. That information was conveyed to the wholesaler, the distributor, and then we just were allotted a certain number of doses. And then all hospitals were basically asked to opt out, meaning you get the drug, here is the quantity you're going to get it, but you may opt out. So everyone is in unless you opt out. And that's how the drug was distributed. So that was part one. And that was the state's responsibility to come up with an ethical and equitable framework for how the product will be made available to all Wisconsinites. When the drug then arrived at every hospital, then it became a hospital, basically on the hospital to come up with a model or a framework for distribution to patients. The state, of course, in the framework, they said, you need to adhere to the EUA criteria at minimum. If you want to prioritize beyond the EUA criteria, you need to follow our ethical framework. And the state issued an ethical framework document that basically tells us if you want to go beyond the EUA criteria, then you need to follow these guidelines. So that's, on the macro level, on the state level. When it came to the drug, when it arrived at my health system, SSM Health in the Wisconsin market, we have 7 hospitals and several clinic and infusion centers across the state. When it arrived at our hospitals, then we came up with our own model. And we looked at our own data and we realized that if we followed only the EUA criteria, we would be, we may run out because it's very broad and many patients would qualify. And number 2, we realized based on the available data to us from Lilly and later on from Regeneron, it seems, especially from Lilly, it seems that the product was not very beneficial when it's given more broadly. So we thought if we highlight a group of patients that are at a higher risk for more severe disease, at a higher risk for hospital admissions, and we tried to quote unquote target this patient population to make this product available to them, the benefit will be greater. So how can we identify patients that could benefit from this product more than others? And we follow the EUA criteria, but then we realized we need to also add a few more criteria that was also part of the state framework, looking at certain comorbid conditions. We applied a weight for every comorbid condition. And we came up with a scoring system. So for example, being male, sex is 2 points. Age, for example, we add points as the patient is, in the older age brackets. High risk comorbid conditions like diabetes is 3 points and so forth. And we added, all of it adds up to a score. Based on that, we created this report in Epic. And then we created a process, and maybe I can present my screen if I can. Let me see if I can.
Yeah, I don't know if you'll have the ability to share your screen, Mohammed. Lisa or Emily?
Let me see if I can. Can you see my screen?
Okay, yes. Yep, you are starting to screen share. There we go.
Okay,
Thank
perfect.
you.
So I'll try, I don't know if I can make this bigger, maybe I can. So then we came up with this framework at my health system here in Wisconsin. We said every day we run a report for all positive results from the prior 24 hours. And we apply this report from Epic comes to us already with the scoring system. So every patient who tested positive, they have their scores next to them. And we decided to come up with a cutoff uh, and look at patients with a higher score, meaning they are at a higher risk for severe illness. And then once all patients on this report, we basically, if they meet the EUA criteria, of course, being on this report, they will, but just one more time to double check this. If they don't, that ends the process. If they do, then we basically call the patient, explain to them that there is a treatment that's available to them. One other component I want to add, in the EUA, it said it should be given to patients patients who had symptoms for 10 days or less. We decided to go with 5 days or less because we believe the sooner you give this product in the disease process, the more effective it is. And if the patient says, yes, I would like to try this treatment, we will then schedule them. And we send an in-basket message to the primary care provider. So this is done by screening or scheduling. We have a group of care management nurses who do this work for us. Then when the patients arrive for the infusion, they are checked in. We do basic screening to make sure they are eligible for the infusion and they have no other contraindications or precautions. And we release the order from Epic. We prepare the infusion, we infuse, and then the patients leave with an after visit summary. Of course, they wait in the center for, I believe, an hour to make sure that they did not react to the product until it's safe to release them and to discharge them home. And also at that point is when we send a message to the provider also for a post-infusion follow-up. So, so this is how the process works. It took us a few weeks, and initially we felt bad because we have the drug available to us. It's sitting in the fridge. It's not being used. And while we're working, the process to come up with a report, agree on the risk criteria, so our infectious disease physicians or primary care docs, we wanted to agree on high risk criteria and agree on a cutoff, and then come up with this workflow. One other comment is based on our own predictive analytics model that we created based on our own data, our own COVID patients over the past several months. We concluded that that this high-risk group of patients is a group of patients that are 38% more likely to be admitted to the hospital unless another intervention is offered. So we tried to narrow it down to patients who are truly at the highest risk for severe disease and for a hospital or ED visit and hospital admission based on our own predictive model and of course based on the EUA criteria. So this is our model. We finally figured it out, and I'm glad to say we began infusing only this week, but we infused a few patients, and more are to come. And the report is running as designed on a daily basis, and that's what we did.
Great. Thank you so much, Mohammed. A quick clarifying question for you. Based on the point scale, if there are restrictions on the supply, do the awarding of the ordering of the monoclonals default to the highest point totals, or within that high-risk group, is there an allocation formula that's applied?
So based on the report that we run every day, all positive patients show up on the report, and they are basically with their scores, and they are sorted in order of their score. And at that point, the care manager, before she begins making phone calls, she checks with pharmacy to know how many doses do we have. And if the doses are limiting us, then we'll go with the highest tier. But if we're not limited by doses, like now we have a supply, we stop at a certain cutoff because below that, we believe the drug may not add benefit.
Great, thank you so much. We're going to make a slight change in our order right now and move to the state of Massachusetts and Dr. Larry Madoff, who is Medical Director for Bureau of Infectious Disease and Laboratory Sciences at the Massachusetts Department of Health, since he unfortunately has to leave us for another meeting obligation. So Larry, thank you so much for taking the time.
Thank you, John, and thank you all. You can hear me okay?
Yes, no problem.
Great. So thanks very much, and I've really enjoyed today's session, and thank you to you, to Dr. Zhao, to Dr. Feinberg, and to Dr. Wazinska for planning this session and for including us in the discussion. Massachusetts has, of course, faced largely the same hurdles and difficulties that I think all of the other states have mentioned and expressed. Other jurisdictions have talked about going through this. It began as it did for the other jurisdictions with the emergency use authorization, and then pretty quickly by allocation from Health and Human Services to the states of this product, and it bore a number of similarities to the process whereby remdesivir was received, and also how we met that a need for allocation within the state. And so we actually stood up the same working group that had worked around remdesivir to help formulate how our state was going to manage the allocation. I also want to mention that we were given a valuable heads up on this when we had some conversations about a remdesivir allocation by the Duke Margolis Center, who actually sort of highlighted for me that this was a train coming down the tracks, and that we would something that we needed to think about. So it did give us a little bit of a head start in thinking about it. The working group met, and we had this group comprised infectious disease specialists, including Dr. Rochelle Walensky, who will become the CDC director, and a number of other infectious disease specialists, as well as community health specialists, a medical ethicist, and some representatives of state government, including me. And we met and discussed the allocation, and also talked about the potential benefits of the monoclonal antibody, initially the Lilly product, and then the Regeneron product, and there was and what the available evidence was, and who would best benefit from this, and of course, the very difficult questions of logistics and how to deploy a drug that needed to be provided by intravenous infusion, and at a period when a patient was most infectious, when most of the infusion capacity in our state was frankly around cancer chemotherapy and other patients who were immunosuppressed for other reasons. And so this certainly presented difficulties. The working group had a fair amount of skepticism as to the overall benefit of the therapies based on the available data, and so thought that it best to be careful and deliberate and walk slowly through the distribution rather than rush into it. And also the group and the department were very concerned about equity issues around the drug, given particularly the sort of celebrity status of the drug, how it had been used in prominent people, and their seeming ready access to it where others where it wasn't available to most or to many, and the obvious supply shortages that were likely to occur given large numbers of cases that were beginning to occur in Massachusetts and as well as nationally compared to the number of doses. And of course, the EUA criteria, which as others have mentioned, were quite broad and inclusive, and certainly would include many potential patients. So the system that the working group developed and that the Department of Public Health implemented is sort of two-phased. The first is an allocation to hospitals. As my Colorado colleague mentioned, we wanted to make sure that it was equitably distributed geographically. So we divided our allocations by our 5 emergency preparedness regions in the state. Of course, we have a much smaller state, and it's hard to be anywhere that's more than 90 minutes from anywhere else in Massachusetts, but we still wanted to make sure that all residents of the state would be eligible to receive it. And we adjusted the allocation to the regions based on both the number of hospitalizations for COVID, a rate of hospitalizations in a region, and by the overall social vulnerability index scores of a particular region. And those were weighted equally in the allocation. And then finally, by allocation, by infusion capacity of the facilities in that region. And so we also developed a system for equitable distribution based both on clinical criteria and also on perceived social equity and disease incidents. And so that system involved within each hospital system that was administering the drug, and of course this was initially rolled out just to acute care hospitals, we asked that each hospital utilize a system where 80% of the allocated infusion capacity or doses, whichever was limiting, was allocated to everybody who was clinically eligible, with the highest tier being those older than 65 or with a BMI greater than 35, so the highest risk individuals, and then secondarily to other individuals who met the EUA criteria in some other way. And we did include the potential for children to be included in that group. The second part of that allocation, an additional 20% of the allocation was reserved for vulnerable populations. And so these we defined as people who were coming from the highest tier of social vulnerability index based on their residence. The CDC's social vulnerability index, which is available by census tract and zip code, as well as town, or they were coming from a town that was in the highest quartile of case incidence. And so those patients from that population were eligible in the reserve category. And then within each category, we instituted a lottery system so that the available doses would be made available randomly on a daily basis as capacity allowed within each system. We also instituted a number of requirements for the healthcare facility that were around safety of the infusion site, around their willingness to put forward a public-facing telephone number so that providers and patients could reach out to them, and also their ability to report back to the department on a weekly basis with parameters that would let us ascertain the appropriate use of the drug, both by clinical criteria and by equity considerations. So we've just started rolling this out. Of the 70 plus acute care hospitals in Massachusetts, it finally came down to about 11 who were willing and able to meet those criteria. I will share, if I can. This is just a map. I hope you can see that, of the infusion sites against the incidence rate of cases here in Massachusetts. And fortunately, these aligned fairly well. And this has been a appropriate, we believe, geographic distribution of healthcare facilities. There's still quite a limited infusion capacity. And so that is a rate limiting step for us. So that's what I would have to say at this point, and I will turn it back to John. And thank you very much for allowing me to participate in this symposium. Thank you.
Great you're able to join us, and sorry that you do have to leave for another meeting. And before you go, I just want to ask a quick question. So the lottery mechanism, that's that secondary allocation step, is that statewide, and does it direct the person to a specific healthcare system or entity that has the medication, or does it just give them a green or a red as far as a lottery win? How does that work?
So yes, it's a green or a red, assuming that the slots are filled within each of the allocation categories. And that lottery is actually performed by the healthcare institution. So it's at a regional, it's at the healthcare system level. We do ask that hospitals accept patients who are not part of their healthcare system as part of being able to participate in this in this process. And as I say, to have a public-facing phone number for providers or patients to reach out. I didn't mention, of course, also the time limitation. We expect we're using the 10-day EUA timeline.
It's amazing how fast that 10 days can slide by. So, well, thank you, and appreciate all the work you're doing in the response.
Thank you, and thanks to all of the participants today. It's been really enlightening.
Thank you. We'll now backtrack a little bit back to the Midwest for Megan Klatt from the Infectious Disease Pharmacy at the University of Michigan School of Medicine. Megan, thanks for taking time today, and sorry to jump out of order here, but appreciate your flexibility.
No problem. Thank you so much, Dr. Hick. It's truly a pleasure to be part of this discussion on monoclonal antibody therapies for the treatment of COVID-19. I'll be presenting a brief overview of our monoclonal antibody allocation framework at the University of Michigan Health System. As a brief background, University of Michigan Health System is a large academic medical center comprised of about 3 hospitals, 30 health centers, and 120 outpatient clinics, primarily serving patients in southeastern Michigan. Our COVID-19 monoclonal antibody efforts started approximately 1 month ago following release of bamlanivimab under FDA EUA. At that time, we had 3 groups within our health system: our COVID-19 task force comprised of hospital leadership, our scarce resource allocation committee, and our pharmacy and therapeutics committee, all of which collaborated and worked together to develop our allocation method and criteria. As a large academic institution, we receive positive test results from a variety of different sources, including emergency department visits, our COVID-19 hotline, occupational health services, our university health services, which primarily caters to our college students on campus, and individual clinic visits. Thus, our goal with allocation was to create a centralized allocation process in which, receipt upon a positive test result, we could screen, notify, consent, order, and schedule drug administration all within one system. As the system currently stands, all positive test results within the University of Michigan Health System are funneled into a best practice alert, which identifies patients who meet our allocation criteria. At the onset, our allocation criteria was designed to specifically target those patients at highest risk for progression of their COVID-19 symptoms and hospitalizations, which we particularly defined as those patients who are elderly, obese, and immunosuppressed. These definitions were decided upon after a very rigorous review of the current literature to date, including the BLAZE-1 study, the bamlanivimab EUA, and press releases from Regeneron. But once patients test positive and meet our criteria, they're then filtered into a pharmacist inbox for screening. Our pharmacists work under a collaborative drug therapy management process to review, screen, consent patients based on a first come, first served basis from the time of their first positive test result. Patients will then review the chart to ensure the accuracy of the BPA, and then we'll call each individual patient to screen for type and onset of symptoms. Then if patients meet criteria, we perform consent process over the phone. We obtain verbal consent. We'll then order the bamlanivimab or the Regeneron product, and then work with our medication infusion specialist team to schedule infusions. Patients currently receive infusions at an off-site infusion center about 3 or 4 miles away from our main campus. This site was chosen in particular because nursing staff was already very comfortable caring for COVID-19 patients, and specifically, this infusion center has private rooms to minimize exposure. So far, we've been very pleased with the status of our allocation process. My unique perspective is I was the first pharmacist to start screening patients and have continued to be very active in this process on a day-to-day basis. So as such, I can tell you that this particular method is very effective in specifically targeting those high-risk patients and obtaining a lot of different patients from various treatment or testing sources rather. Additionally, as a team, our efficiency has improved and we're able to screen more and more patients every single day. The biggest challenge that we've encountered so far has been ensuring appropriate number of nursing and pharmacy staff to support these efforts. Luckily, we've been very fortunate in being able to train new individuals to help us with this process. In the future, we'll be expanding our current allocation criteria to align with the Regeneron product and bamlanivimab EUAs as we receive more drug. And we're very optimistic about continuing to provide this service to patients in the months to come. So thank you again for inviting me, and I look forward to the moderated discussion.
Thanks so much, Megan. How does your system handle a person who tests positive in the community but is not necessarily a member of your health system?
Yeah, so at this point, they have to have a Michigan Medicine or University of Michigan Health System MRN to receive drug product through our health system. If they have any sort of encounter through the Michigan Medicine Health System, then we would provide them drug. Otherwise, we will direct them to other hospitals within the area.
Okay, thank you so much. Well, I would have thought we would have kept the Wolverines and the Buckeyes a little bit more separated on the agenda here, but we're going to go now to Tricia Jordan, who's the Director of Pharmacy Clinical Services at The Ohio State University Wexner Medical Center. So Tricia, thank you and welcome.
Yes, thank you. I love the introduction of the Michigan and Ohio State connection. It was great. Well, good afternoon, and I'm pleased to be here today to discuss our allocation process. We're so excited to have a treatment option, and OSU likes to be first. So I think some of the guests have shared that they were maybe just getting started or like the development of the process. We did it really pretty quickly out of the gate. And I think partly was we had participated in the initial investigation of these products. And so our team was really comfortable, our providers were really comfortable with the products. And so there wasn't as much delay with getting started. And so some of our allocation constraints were really, our goal was to maximize the number of patients we could be treated. Similar to what some of the other guests have shared is, we were very concerned about equality and ensuring that distribution to all patients that met the criteria. We needed to develop a very streamlined process. We had to stand up a completely separate infusion center. All of our current infusion centers, we did not want to disrupt, given the disruption that had already occurred earlier in the pandemic. Because the supply chain we knew would not be sufficient, we did, similar to some of the other guests, we did stand up our allocation of scarce medical resources framework that we had used previously and put this in place for determining who is going to be able to get the infusions. Some of the other thing that we needed to consider was that our catchment area is much larger than just Central Ohio. So being able to know that we're going to be pulling patients from potentially larger than Ohio in surrounding states. And so we, November 9th was the initial date where the product was going to be released. We got notification on the 13th that our site was going to be getting the medication on the 16th. I think we received the medication at about 12:30 and we had it, I think, excuse me, infusing by 1:15. And so we were definitely ready. And then the Regeneron product, we followed the same time course. To streamline the process, we did develop an e-consult process, which allowed any provider to be able to refer patients in. We did shift pretty quickly into having more of a centralized review where we were reviewing all positives that were resulting within the organization. And that really did give us a better grasp of who was positive and based on our criteria, who would be eligible to receive the infusion. We did go with essentially the same EUA criteria. We made 2 modifications. Initially, our only modification was decreasing the number of days of symptoms to 7. And then based on the supply chain, we just recently changed the BMI criteria to greater or equal than 40. Our allocation resource committee does meet weekly based on, and that's mostly just based on the need for us to consider, do we need to make any additional modifications? Our primary site is the infusion center that we did stand up to treat these patients. We do see patients that come to the emergency department. We will treat them there. That's not something that we advertise. We try to keep that really close to the vest, so we don't want really an influx of any more patients. But if the patient does meet criteria, we will infuse them there. And so we have a two-tiered system in our emergency department where the emergency provider can put in the request, and then our emergency medicine pharmacist will approve that request. The product selection is really based on our supply. We do use one product for that week, and then we alternate supply based on the product availability. And then just a couple of lessons learned. I do think our framework has been very successful. Our supply, we've continued to get some. It's been a little up and down in terms of what we are getting each week. So that's just been a little bit frustrating for us because we want to make sure, as everyone does, that we have the right supply. We do have patients traveling from out of state, I think more than we thought, and that's mostly based on our large cancer institution. And so we're pulling from far states. So just making sure a patient can get here within 7 days from the time of symptom onset. And then again, we haven't had to modify the EUA criteria again, but we did make those initial 2 criterias. We have noticed that we might have been, as we were first out of the gate in our area, we've been borrowing because our allocation, I think the allocation really isn't based on use. And we had made that suggestion to HHS to consider that. So if you're actually using it, maybe you should initially get more allocation. We've been borrowing from other health systems that hadn't started that process. And I think one other thing we had learned was really sharing our results. So we've actually implemented this process in a prison, one of our large prison systems in Central Ohio, and then also in a long-term care facility. So our goal is not to bring the patients to us as much as if they're in more of a consolidated health setting, that we can bring the product to them. So we have now implemented this process in 2 different settings. We still get the results. We review them similar that we would to any other patient that would be coming to our organization. And then we infuse the product in those locations. Thanks for having me today, and happy to take any questions.
Great, thanks, Tricia. Just a quick follow-up question. It sounds like so far, mainly it's been the EUA criteria that have been used with a few adjustments. So it sounds like you haven't yet run into any shortage issues. Do you plan on any specific allocation system, randomization, or anything else if it gets to the point where there's too many people and not enough medication?
Yeah, we've talked a lot about that. I think what we would do is we've talked about they would have to meet 2 criteria. I think that's our next step if the Scarce Resource Committee would take that next step first. We really don't want to get to a randomization, but essentially we're sort of tightening the criteria, which would then changes the allocation of who would get the supply.
It's so hard not having enough clinical info to know whether additive conditions mean that, additive risk, or, 2 conditions doesn't mean twice as much risk. So tough sledding there, but thanks. And it sounds like you guys got out of the gate early and effectively. So we'll move out to back to the East Coast, and John Sanders now is the head of the infectious disease section at Wake Forest Baptist Health System. John, thanks for taking time today.
Hi, thank you for having me. For those of you who are not aware, Wake Forest Baptist Health is one of the medical systems here in North Carolina. We cover Central and Northwest North Carolina. We are now part of the Atrium Health Enterprise, which covers about 40% of the state, most of the Central and Western North Carolina side of the state. And similar to what has been presented already, the state of North Carolina developed an allocation plan that followed on the same plan as remdesivir allocation, going to sites that had previously operated remdesivir out of the EUA. So we received that, and we started our allocation program on November the 23rd. And I'm just checking to make sure you can hear me, because you have frozen on me.
Oh, you're good. You're great.
Yep,
Okay.
loud and clear.
I'm in Minnesota, so I tend to freeze up a lot, but you're great.
All right. Thank you. So we started our allocation November the 23rd, and we did so following a similar pattern that we did with remdesivir when it was at EUA and other EUA products. We have an action team as part of our P&T committee dedicated to looking at all new COVID therapies and COVID products and regularly updating our guidelines. We reviewed all of the publicly available data and decided to make it a little bit more restrictive here than the EUA, focusing on those patients who clearly had an immunocompromising condition and had not developed a new oxygen requirement in which we would have assumed that they would be headed to hospitalization. Took us a little effort, but we identified 2 of our infusion centers that are about an hour apart from each other with private rooms to allow people to access one of those infusion centers. They should be no more than 45 minutes to an hour drive from any of the 27 county catchment area that we cover. So we set that up into place, put out messages and information, and requested that physicians taking care of these patients would refer them in and provided an EPIC order set for them to do so. That would route through our on-call committee, on-call review committee to approve it and to contact the patient for any necessary paperwork. For what it's worth, though, despite this setup, we've had very, very little activity, very few referrals. And so we've not exercised the program as much as we thought we would, despite being up and running since November the 23rd. So I will say that our biggest limitations going in were logistical limitations. Identifying appropriate spots to do the infusion, identifying the appropriate personnel to consent and provide the infusion, and then making sure that we were not taking away from the work that we're doing, trying to drive people into the randomized clinical trials such as ACTIV-2 in deference to this program. So we have maintained our clinical trial group and set aside these infusion centers at other locations. So I think that about covers the Wake Forest experience. Now I'll pause for any questions and look forward to the session.
Absolutely. And most of the questions will be at the end, but I just wanted to clarify. So it sounds like there is still a randomized trial ongoing at the main Wake Forest campus. How has that enrollment been going since people are aware that they can get the medication now, outside of a study process?
Well, that part of the reason that we restricted it to part of the reason we restricted the EUA accessibility to immunocompromised hosts that we were hoping to move the less vulnerable patients who wanted to access these drugs into a randomized clinical trial. Unfortunately, I will say that recruitment for that trial has not gone well either. We just have not generated a lot of interest in this therapeutic option among our providers or among our patients in this region.
Great. Well, thanks again, John. And for our last speaker, going to Emily Sidner-Spivak, who I'm sure by rights of lottery, I've butchered at least one of her 2 last names here, who's an associate professor of medicine in the Division of Infectious Diseases at the University of Utah. Emily, thank you for your comments today.
Thank you. Can you hear me? It won't let me start my own video.
Yes, no, your audio is just fine.
Okay. It says the host is controlling the video. Oh, there we go. Okay. Thank you for having me. I'll try and be brief in the interest of time. Similar to what others have described, just to understand my role. So I'm an infectious diseases physician and the director of antimicrobial stewardship for University of Utah Health. And I am involved and have been with remdesivir and with the monoclonal antibodies at a state level and also at the University of Utah Health. So for when we caught wind about monoclonal antibodies likely getting EUA approval, we reconvened what is called our Utah Allocation of Scarce Medications Committee. This is a subcommittee of our state crisis standards of care that was put together at the beginning of the pandemic and really originally around remdesivir. And as others have mentioned, that committee has, for both drugs or for all these drugs, has had two main goals. One is to decide how to allocate the drugs across the state, but then also to define equitable and shared clinical criteria for prescribing. Again, we did this for remdesivir, a much bigger and more difficult task for monoclonal antibodies, but reconvened this group for monoclonals as well. This group is represented by, there's representation from the 4 major health systems in the state of Utah, which is us at University of Utah Health, Intermountain Healthcare, HCA, and Steward. There's also state Department of Health representation. We have an ethicist. We have some rural hospitals that are non-university or Intermountain affiliated, had representation from those groups, as well as some long-term care facility representation. And in that group, we addressed all the issues that everyone has brought up. And when we started with allocation, we really have, we came upon allocating across the state really based on what infusion capacity was. So there were many infusion centers, mainly within University of Utah Health and Intermountain, but we had differing capacities. How many chairs did we have? Where did we have these infusion centers? Are they spread out across the Wasatch Front, which is the main valley here around Salt Lake City? And then to be honest with you, there were some health systems that were not really interested in providing this drug. So a lot of it has fallen to the university and to Intermountain Healthcare. So our state allocation has not so much been based on COVID census or COVID rates in varying areas, but really where the infusion capacity was, with also some, the university, our allocation is designated and we share with the rural hospitals that are non-health system affiliated. Then within this group, and I have to point out that this was led by a wonderful colleague of mine at Intermountain Healthcare, we derived and validated a risk prediction score to predict on a cohort of 22,000 COVID positive patients in the state of Utah that really better predicts in our estimation and based on the data, 28-day mortality and hospitalization rates. Because when we applied the EUA criteria as written, it identifies about 28% or 30% of all COVID positive patients in the state, but we only had enough drug, or in the foreseeable future, we'll have enough drug for about 2 to 5% of patients. So we derived and validated this risk prediction score with the main predictors or covariates being other things that people have pointed out, but we have weighted these based on the modeling sort of covariates or the prediction scores. And it's, gender, non-white, race, ethnicity stands out as a very strong predictor, even when you adjust for comorbidities, diabetes, obesity, immunocompromised, and then again, age, which we have different point scores as you go through the different decades of life. So depending on where we set the threshold on this risk prediction score, where we have it set right now, it identifies about 8 to 10% of our COVID positive patients, so a smaller subset, and they're more likely than based on EUA criteria to be hospitalized. So about 28% of those patients are hospitalized versus if you look at the EUA criteria, it's about 15%. So we are using this risk prediction score. The process at the moment is that to varying degrees, patients across the state, regardless of where they get tested, with their test results, receive information that there may be a therapy that they may be eligible for that's a novel therapy, and they are directed to a state website through the State Department of Health that describes the criteria for use, has this risk prediction score that the patient can do for themselves, and then has a list of available health systems and providers who can prescribe the therapy if they meet criteria. And then that's where you get referred into, essentially, or you can reach out to different healthcare systems. And at the University of Utah, essentially, we have a phone number where patients or providers can call in and be referred. They then get in with an urgent care virtual visit, because our urgent care providers essentially did not have a lot of encounters due to the way that we're doing testing and things off site. And they are rescreening patients to meet criteria. And then if they're eligible, get them in same day or the next day for an infusion visit. Intermountain is doing a similar process. Again, once they go through the state sort of initial patient screen and then get into one of our eligible providers, they are essentially rescreening them as well and then getting them set up for an infusion. Things that we have learned is that the patients who need this, as others have highlighted, don't find us the way that we had hoped, but also we knew, it requires going to a website, being notified through your test results, essentially doing some of the legwork yourself. The patients who really need this drug or who may benefit from it are not necessarily going to do that. Intermountain has identified that basically 2/3 of their patients that they've infused, they have to proactively go out and find. So they screen, they have a registry, and we have now built one as well, of all COVID positive patients, where we are also able to pull in some of this data, if it's in our system, for this risk score, and identify and sort that list essentially daily by who's the highest risk. And Intermountain has figured out that they have to, of the patients that they've infused, 2/3 of them they have proactively called. So they're spending several hours a day and have some providers dedicated to this, to screening patients who are tested in their system and reaching out and calling them. The university is probably going to start doing the same thing. We've now built the EHR tools to identify these patients through our COVID registry list daily. We are also working at the university side, and then the state is also doing this, educating and reaching out to our minority community education groups and community groups to make this aware, make these communities, these vulnerable communities who are probably more likely to benefit, or at least higher risk for poor outcomes from COVID, to make them aware that this therapy may be available for them. The other thing I just want to say is that we've also built tools within our EHR that we now have a report, which we want to track outcomes of these patients as well. And so we have a report built to track outcomes, essentially subsequent ED, urgent care, hospitalizations, visits, so that we can get a sense again of what's happening to these people after they receive these infusions. I think that is the main thing, and I'll end there and just say thank you for having me, and happy to take questions.
Oh, great to have you here, Emily, and thank you again. We'll start the discussion period actually with a question for you, since I happen to have my hooks in you right now. So it sounds like a statewide website screening process is used for conditions that would predispose an individual hospitalization, which has been a little bit of a recurrent theme here, and interesting, because we don't have a lot of better evidence amongst the different, areas within the EUA that have been considered at risk. How do you feel? And you mentioned equity, and I think that's such an important thing. And I've actually got a couple of questions about that. But from a website standpoint, those communities that may not be as electronics literate, may not really be reached, may also have, some fears, quite honestly, of experimental, medications. What efforts are being done or are needed, to better reach those populations? And after I get your comments, I'll open it up to the rest of the panel for comments on that question.
Yeah, I mean, I think it's become so clear and our state group meets every week, and it's become very clear we all have this drug, and again, we're going to have to go out and find people. So what's being done is the outreach at the state level. The university specifically is reaching out to these communities and trying to get some community advocates to share our information. We're also now putting up posters and flyers at our testing centers, so we don't do as much drive-through testing now. It's really cold. It's brought inside, and so we're putting up some flyers in Spanish and English, and patients are also being handed some essentially cards or postcards when they're tested that says, if you have this, it lists sort of some of the criteria. And I made them say, we need to have some language. I don't know what the appropriate language is, but whatever the PC language is around, if you are essentially in a minority, sort of a community that's vulnerable to health inequities, you may qualify. And so then it gives them the number essentially to call us and ask further questions if they test positive. So we're giving that to them at the time that they're getting tested, in addition to some, when the results come to them, some back end information for the positive results as well.
Nice. Other comments from the panel on this question? No one else willing to help solve the equity issue. All right, I'll throw this to Tricia then. You know, it seems certainly we're all trying to do the best we can with the evidence available with these medications at this time, and yet I'll just throw out there that if I was in a different part of Ohio, not part of the OSU system, and was, you know, had a slightly different body mass index than your cutoff, that I might be eligible in some areas or just across, you know, the state line. What are your thoughts on that? You know, how do we make sure that we have as much consistency as possible? And yet, you know, sort of stay within the evidence that we feel is best.
It's because we increased it to 40. We did talk about that, and I think if we had enough supply, we would like to strictly stick with the EUA criteria. And so I think if the supply was sufficient enough in all areas, I think that's what you would see is health systems and infusion sites using the EUA criteria. So we would capture those people. I think if there was some other risk factor, we would definitely consider infusing that person. But I think you bring up a great point in that, you know, depending on where you are, the criteria could be different. And so I think that does put a lot of question into everyone's mind of, how do we do this, you know, in a standardized fashion, and how do we make sure we're treating everybody equally? But yeah, it's a great point. And I could see that happening where if you happen to live in a different area, and so we think about our catchment area, Ohio is broken into 3 zones, you know, in a different area, even if that was our patient still, would we try to, you know, our goal is to keep them in what they're referring. So they can come to us for sure, but if they were in a different area where there was an infusion center that was using it, we would obviously like them to stay where they are, because it's better than traversing the state of Ohio, stopping in rest areas. I mean, we just think about how they're traveling as a positive patient. But if they can meet the criteria there, we would obviously keep them there.
Great. You brought up, I think, a really important point about quality assurance and review on a weekly basis. Can you say a little bit more about that and why that's such an important thing as this evidence is so rapidly evolving?
Yeah, so we meet every week to look at any new literature that's come out, whether it's you know, in a peer reviewed or any sort of an abstract, and we're also looking at any adverse effects, any patients that have been admitted, any patients that have had any like repeat to the emergency department, so anyone coming back. So we're looking at all those quality indicators to see if is anything we need to do to change our criteria or anything we need to look out for. So far, we've determined it's mostly all disease progression, and we haven't had to change anything else based on the criteria or any new literature. But again, we're continually looking at that and really ensuring that there's nothing we needed to do for that next day or even that same day to change our current process.
Great, thank you. I'll just throw this to John Sanders. Do you think IDSA or other, you know, whether it's non-federal specialty organizations, other organizations should be doing, you know, that kind of work and coming out with updates or coming out with a little bit more consistent recommendations? What are your thoughts?
Oh, yeah, absolutely. I think that that almost all health systems like ours look to the IDSA guidelines, look to national recommendations from CDC and the FDA. As well as doing our own analysis, and having consistent and regularly updated guidelines is critical. As Tricia mentioned, you know, we meet at least weekly and review the literature and try to make sure that we're keeping our local guidelines up to date. But quite frankly, when we get out of step with IDSA, it makes us nervous. So we very much want those national groups to be taking the lead at putting out clear, consistent, and regularly updated statements on these treatments.
And it's a little tough because NIH and IDSA both said that they can't recommend use. At the same time, I think a lot of people misunderstand that neutrality as being a condemnation of use, which has not necessarily worked, you know, to anyone's advantage in, you know, learning more about these therapies or getting them out there. Any comments that other, you know, panelists have about that? What are you running into? Are you seeing, I'll just pick on Mohammed from Madison here. What's your decline rate right now from individuals that you're approaching through since Epic is identifying the patients for you, what's your decline rate?
Yeah, we just started recently, and out of the patients we contacted this week when we started, I would say the decline rate is about 50%. So almost every other patient that we contact accepts, and every other patient basically says, I don't think I'm ill enough or sick enough to come in for this treatment. I should also add another comment that it's not just overcoming the point of how to convince patients that this is a therapy that can benefit them. It's also here internally. Not every physician is convinced. Certainly, mainly our ID physicians, who are not totally sold that this treatment even adds value even to patient care in a way. So, and it doesn't help sometimes when the physician, him or herself, are not totally convinced either. So it's hard to convince the patient when they call their provider and their provider say, well, I don't know if you need this.
Absolutely, and it's hard, and we'll talk more about this in a subsequent workshop session, but gathering ongoing data about efficacy is just so important here. Megan, you were nodding along with Mohammed about the take rate. Are you also seeing about a 50% decline rate?
Yes, that's correct. And I can tell you from my discussions with patients, the most common reason that they will decline is because they're feeling better, that they had that initial wave of symptoms and now they present with just a runny nose or just a residual cough. And so they weigh the pros and cons and decide that that's not the therapy that they want to pursue at this time.
Great. Eric, a question for you. Your lottery system in Colorado offers sort of instantaneous results, which is pretty attractive. How does that incorporate new therapies that may come along as the antibodies continue to be supplied? It looks like there's other EUA things in the chain. Is there potential for that, or is it going to have to be separate lotteries for separate therapeutics?
Well, we could imagine that we may need separate lotteries, or at least build within it the ability to go to different pages based on therapy. With the two therapies we have now, we consider them equal, and so we haven't had to work on that. We've had our challenges. There's a training about how to use the lottery by each of the healthcare systems, a requirement that each healthcare system uses the lottery in order to be using the therapies. We initially were sending some email information to infusion centers, and then recognized that this had PHI, and we had to restructure it. That required giving an ID and training more people on how to look up for patients. And so there's been quite a bit of manual work when it comes to just signing people up and managing how to use this lottery system. And at the same time, though, we've kind of insisted that it's a bedrock piece of how we're doing our work.
It's certainly the instant feedback, is certainly an attractive part of that. Jeff, your comments, if you're still with us here from the New York standpoint, how much time delay is introduced by that allocation review committee?
It's not proven to be a bottleneck. Usually the turnaround time is within an hour.
That is rapid. Congratulations. I can't get much of anything in an hour at my hospital. And my hospital I consider to be really good. So, okay. And so and how does that approval come to the provider? Is that a message through the EHR, or how is that communicated?
No, that part of the system is done by email.
Excellent. So it sounds like, Mohammed, in the state of Wisconsin, some of the allocation to the counties, and I believe this was echoed by one other speaker, I believe Eric, that SVI, or Social Vulnerability Index, was being used to allocate to the regionally. To your knowledge, has there been any effort to allocate, specific or any thoughts about allocating, specifically prioritizing, people from SVI areas or any other priority groups, essential workers, healthcare workers, long-term care residents?
As of now, we did not prioritize healthcare workers or in Wisconsin, but counties with a higher SVI will get more doses allotted to them, meaning a bigger number of doses will go to the hospitals in these counties, with the assumption that these are the counties where we have the most need, and number two, the population seems to be more disadvantaged. And as far as long-term care, that's another area that we're looking at. It's my understanding that we're working on we will update the framework to add criteria for distribution to long-term care facilities, skilled nursing, and assisted living facilities, with the new guidance from, I believe, from CDC on having a national provider, I think it's Omnicare, to help administer infusions at SNF locations, so patients don't have to go to a hospital or an infusion center for this infusion. So knowing that the nursing homes in the state, or in every state for that matter, will get their allotment from the state allocation at large. So we had to go back and find a formula for how the allocation will be split between health systems and nursing homes as well.
Yeah, it's there's an awful lot of math and allocation here, you know, whether it's with the doses or after the doses. Others that have comments about any priority groups or sub-priority groups within your state, within your organizations?
I have to say I'm struck by the variability across our programs in terms of how we've done prioritizing. Our own state said early on that with the EUA saying all of these people are eligible, we felt like almost from an ethical place that we really couldn't prioritize it, especially since we didn't have the subgroup analyses that really showed that one group had preferred outcome over another. And yet, and there seems to be maybe a varying view of how flexible we can be with an EUA. It seems interesting that would we have that same approach if these were licensed? In the times of scarcity, there maybe needs to prioritize one group over another, and I don't know that it would be fair or equitable that depending on where you live in our country, you have different access to these medicines, not only based on just geographic issues, but variations across prioritizations. And maybe this workshop will help clarify the need to have some standardization about who should be first when we have these scarce resources.
Yeah, I agree. I think it's so hard, you know, when we have so many so little information about the efficacy of the agent, so many potential qualifying candidates, and so little information, you know, to guide us on actual risk for the conditions we're trying to prevent, you know, hospitalization, death, as well as some very disproportionately impacted at-risk communities of color, other populations. One other population that has come up in question has been the prison population, and whether or not they're receiving any of these therapies in place. Do any of the attendees have any comments about that?
I can share what's happening in at least Central Ohio. We are the healthcare organization for our prison system. And so previous to us sharing our process and giving them part of the allocation, now they're getting part of Ohio's allocation. They had not had access. So I don't know if every state is a little bit different, but we realize and recognize that was a vulnerable population that needed to have access. And so we did share that from, again, initially our supply, but then the state of Ohio did allocate part of the supply to the prison population. So us sharing our process with them, I think was amazing. And the only other thing I would comment on, it's interesting, the 50% refusal rate. I wonder what the difference is, because I think we've almost done 600 infusions, we've had less than 25 people refuse. It's just interesting. I want to just point out the difference there. It's why there's a difference. I don't know. We don't know, right? But I thought it was interesting when I was listening to the other panelists.
Yeah, that's an impressively low rate of declines. I'd be interested to know from a patient information standpoint, patient communication standpoint, you know, how that, you know, differs, because that's fundamentally different than what we're hearing from most of the systems, where
Yeah.
a 50% decline rate seems about to be the average. So, so as long as I have you on the phone, Tricia, what's your next steps as far as, you know, making this a better, smoother, more automated other process?
Yeah, I think that's a great question to ask, because it is when you think about not only the scarce resource, the healthcare providers, and you know, was a little clunky at first. So we're working really hard on streamlining it and getting it a bit more automated. Right now, we have one pharmacist this could be the difference. We have one pharmacist that calls every patient. So once the e-consult goes in, one pharmacist calls every patient. I don't know how long we can keep that up with the one infusion manager calling every patient to do the education. It could be that she does an amazing job sharing the information, and that's why our success rate is so high. But we really do want to automate it a bit more, and so patients get that information a little more in a streamlined fashion, because she's been on the phone with some patients for a very long time. So that's really our next step. And our next step is really sharing our process with other organizations. And it's mostly these long-term care settings, so they can implement our process. And so we're not trying to bring those patients to us. So really decompressing our process and really shifting some of it to those vulnerable patients.
Absolutely. Especially considering the logistics and the risk of moving those patients, the bringing the infusion to those settings certainly seems like the thing to do. Any other comments from other panelists about the long-term care population? Any either challenges you've experienced, initiatives that you have going, or prioritization within that group?
It's an ongoing conversation here in Colorado. We know that there's also some sites that are involved with some of the new randomized trials looking at it. And so how do we balance enrollment in those trials at the long-term care facilities, as well as being able to provide this across the state in those facilities? In Colorado, I think we've spent so much time at just trying to identify places that were willing to do this and build that basic infrastructure of places week after week, trying to find people who will do this, that we haven't necessarily looked to the special populations of prisons or long-term care facilities, though clearly that is another opportunity that we should be focused on here.
And Eric, as long as I have you on, I have one more question for you. Any thought about using the lottery during vaccination as well, or for other things? And also, it sounds like you've balanced in Colorado allocating by region based on vulnerability and at-risk populations, but then using lottery within those regions to allocate, which certainly seems a balance that other states have been striking as well. But comment on thoughts about using the lottery for other things.
It's actually more interesting for us to think about using the catchment areas and risk for allocating vaccines. So if we move into a phase where we're vaccinating people in these larger categories of increased risk or age-based ones, and we have X number of doses this week, how many should go into each of the different counties? We'll probably use this mapping to help us decide where we should send those doses first. Less about using the lottery, though, for the actual vaccination itself. And to date, while we've built this lottery, we're actually, as I said, probably have to switch it to a lottery for infusion seats rather than supply of the therapy, because we probably have more people who like it than places for them to go. So we really haven't had to use it just yet. And we've only done a few hundred interstate overall.
Great, thanks, Eric. Tricia, can I ask you how many doses that you all have administered, since it sounds like you've had an early and aggressive program?
I don't know the exact number today from yesterday, but we were over 600 doses. In the emergency department was about 70 of those doses. Again, that's as of yesterday morning, so give or take a couple here and there. Yeah, it's going really well. We've actually had, I think I shared that we've been borrowing supply from other health systems that are just getting started in our area.
And what do you think the biggest limiting factor has been for you all? Has it been the staff or the space? What's been the biggest problem in coming up with the resources to meet the need?
I think in terms of chairs, so I would say staff. Nursing, our nursing staff has really been the rate limiting supply. So we can do, I think, up to 38, 39 infusions per day. And then we do a few usually out of the emergency department, a couple every day is really, we've had bigger days where we've been able to squeeze a few more patients in based on need, but that's really, we could pretty much cap out at 40 plus a few in the emergency department.
Yeah, staff that are trained to administer IV infusions and deal with anaphylaxis are at a premium, especially during a surge event. So, Megan, you brought up some comments from a pharmacy resource commitment. From a drug preparation, as far as supervision and vetting standpoint, it sounds like it's been about an FTE needed. Is that correct?
Yes, most definitely. More pharmacists that can screen patients and help to all of our pharmacists that are currently screening actually are helping to compound the medication as well. So we need more pharmacists to help to ensure that we're able to give all the drug that we have available.
At least it sounds like you've got one less step with the BAM. You don't have to anymore withdraw the saline out before injecting it. So we can save you about 10 seconds there. But great. Well, I just want to, we're at time, and I could continue this for a long time, and yet we need to go and get this back to Dr. Feinberg. I just want to say thank you, very heartfelt. Thanks for all you all are doing, really on the frontiers, you know, of the monoclonal antibodies, and hopefully, you know, additional therapies to come that will benefit our COVID-19 patients, keep them healthy, keep them out of the hospitals, and help us to turn the tide against this pandemic. So much appreciation for a great last hour and a half. And Dr. Feinberg, back to you.
Thank you so much, John, and thanks to every one of our panelists. This has been an extraordinary tour across the country to a set of leaders who've made some very difficult and impressive decisions and systems to help us make these decisions. One cannot help but be struck by the variation in the detail and the commonality in the principles that you all have adopted in trying to implement systems that meet the need, respond equitably, are fair, transparent, explicable, and usable. I've been struck by the number of you who have emphasized that the real constraints today are more on the supply and availability of infusion centers and personnel than it is, in fact, a shortage of monoclonal antibodies relative to the demand from patients and providers. We've hit upon a number of the uncertainties that percolate through all of the decision-making processes, beginning with the fundamental questions about confidence in the effectiveness of treatment. And it's a very interesting differentiation between the models that are primarily premised on differential risk of hospitalization as compared with any degree of high confidence about differential benefit as applied. And in fact, Marta in her original discussion pointed us briefly to this fact of the difference between confidence about the risk and uncertainty about the benefit as applied to each patient. It's also been very striking to see beyond the detailed differences in choices, such as whether we constrain to 7 days post origin of symptoms or 5 days, or whether we increase the BMI, or whether we select only immunocompromised patients, the number of ways in which additional considerations of populations at risk have entered into the discussion, both about the allocation rules within states to sites or to catchment areas or to counties, and about the final criteria as applied to the selection identification of individual patients. The difference in the acceptance rates that we've heard about from 95% to 50% is another striking feature from this discussion that will bear additional inquiry and consideration tomorrow and beyond. As we look forward to tomorrow, we will try to build on the lessons from the experience on the ground today and from the overviews that we've been provided to try to come to grips with some very critical, principled aspects of these decisions. We're going to spend a good bit of time trying to come to grips with the questions of access and equity from a variety of perspectives. And then we're going to be able to turn to some additional issues related to the cost, related to the production and availability of monoclonal antibodies, and to touch upon some of the global or international distribution and equity issues that also pertain to monoclonals as to vaccines and to every other treatment or preventive that will be applicable to COVID-19. I want to conclude this morning again by thanking every one of our participants, our moderators for such an excellent job in leading the discussion, and particularly our sponsors in the Assistant Secretary for Preparedness and Response Office at the Department of Health and Human Services, Dr. Kadlik, Chris, thank you so much. We're delighted to be able to carry on this work at your request. And I personally look forward with great anticipation to our discussion tomorrow. We're going to reconvene at the same starting time as today. That will be at 10 a.m. on East Coast US time. The same information for linkage to our program will be available as shown now on the slide. And we welcome your comments, your questions, your advice overnight. Please email Lisa Brown as indicated on this slide at lbrown@nas.edu or Emma Fine, EFINE @nas.edu. Thank you all very much. Enjoy the rest of the day. We look forward to tomorrow's discussion. We'll now adjourn.